That's a good trick. That's a good trick to mute it always and all. Put it on whenever you want to talk.
Yeah.
Dr. Navin, I met you in Bellary this time. I don't know.
Yes. I know very well, sir. Bellary, I was there for one day because the previous day I was doing live surgery somewhere else.
Correct.
So, Dr. Ved,
Vijayawada was.
Bobby and Dr. Thakkar, I will ask questions to you, but whenever you want to say something, you can go to this reaction and raise this hands up. So I'll know that you want to give some comment, okay? So there is on most right side of on the bottom is a reaction thing.
Or you just raise your finger or thumb. I will come to know immediately.
So we'll come to know.
Like
You can do this. Yeah.
Yes.
So this
Arnav
is
Goswami, right?
yeah. So that
Absolutely
thing can
right.
be done
Absolutely correct.
like this, okay? Otherwise,
you.
we'll get offended that Maulin is not paying attention.
Thank you.
No. Many times we are so much involved in the subject, so we cannot take that part. So I will take part of that, some of the, and you also check it.
Yeah.
You all will check it. It will be a fun.
નવીનભાઈ બેકગ્રાઉન્ડ જે સ્ટેન્ડ અપ સ્પીકઅપ જ છે
ચેન્જ કરી નાખું છું હમણાં ચેન્જ કરી નાખું સાહેબ મને ટાઈમ નથી મળ્યું tomorrow there are two webinars which are big webinars. Morning it's scaffold and 5 international faculties are, so we were adjusting the times. That was an issue.
કમલેશ તે પાછળ બેકગ્રાઉન્ડમાં શું ટોવેલ નાખ્યો છે?
નહીં
No, it's a like inbuilt of virtual background facility.
એ તો ખબર પડી, પણ વર્ચ્યુઅલ બેકગ્રાઉન્ડ માટે પણ બેકગ્રાઉન્ડ should be clean, ને?
You're live on YouTube, I think.
Now you're live. Now you're live. Huh?
Yeah, we will edit the video. Don't worry, Mandar. We can speak here. We can edit.
No. Every day, one young surgeon wants to know exactly what you are doing behind the screen.
Behind the screen.
Yeah, he wants making.
તમારું તો બતાવો મેકિંગ યાર એકવાર તો બતાવો.
Just a minute. મને પહેલા ચાલુ કરી લેવા દો.
નવીનભાઈ જેમ પેલું સેટેલાઇટ નું બધું કંટ્રોલ કરતા, he looks like
એવું જ છે. It is just like
cockpit, as if he is in a cockpit.
Kamlesh is observing from the
top.
Yes.
Navin will be an international celebrity by the time this corona finishes.
Kamlesh is actually on the top, spiritual top, you know.
I'm expecting an invitation from Trump.
Sir. Chalo, let us start.
Yeah.
So we are very much thankful to all the faculties and Dr. Maulin Bhai for moderating this session of proximal radius ulna, fracture neck femur and Montegia, and he has coined the name confusion to conclusions. So this is confusion to conclusions, and you will get crystal clear ideas from all the faculties. So we welcome all the faculty on behalf of the Gujarat Orthopedic Association, myself and Dr. Kamlesh Bhai as the Honorary Secretary of Gujarat Orthopedic Association. For those who are seeing on the screen, you can see here watch recordings, live webinars. The previous webinars you can click here, and as you go down, click this red arrow. You will get this webinar, today's webinar. And as you go down, there is a screen where you can type your question. And once you type your question, that question will come to us, and just click the button send. And if you do not want to type the question, then record the audio or a video button in a camera in the WhatsApp, and just click this link of WhatsApp. That will come to me, and we'll play that audio or video if the time permits, so that your real question will come in the audio or video format. So let me introduce the faculties. Everybody knows Dr. Maulin Bhai is a young pediatric orthopedic surgeon from Ahmedabad. He is moderating. Dr. Dhiren B. Ganjwala is the president of Pediatric Orthopedic Society. Dr. Kapil Gangwal from the Jaipur. Dr. Atul Bhaskar from the Mumbai. Dr. Anirban from the Kolkata. So we have a spectrum from all the region of the India. Dr. Mandar Agase, again a young orthopedic surgeon from Mumbai. Dr. Rudra Prasad is there from the South, Bangalore. Dr. Gaurav Gupta from Delhi. our own Honorary Secretary Kamlesh Dev Murari from Ahmedabad, Dr. Bobby John from the Ludhiana, and a very senior orthopedic surgeon, Dr. Ved Mida from Gwalior, and we have a professor, Dr. R.K. Thakkar from the Gwalior. So we'll be having varied opinions and we'll discuss this issue. Let me announce that tomorrow there are two webinars. The one webinar is for scaphoid, and there are great faculties in that webinar. So let me open up that site and we can show you that site where what are the faculties there. Tomorrow morning 10 to 12 we have a international faculties. Dr. Sudhir Warrior is moderating. Professor Joe Dias from the Leicester, UK. He is the past president of British Orthopedic Association. Professor Amit Gupta from the USA. Dr. Randy Bindra from Australia. Professor Chaitanya Mudgal from Boston. Dr. Sumed Talwarkar from Renington. Dr. Hemant Patnakar from Mumbai. Dr. Ram Chidambaram from Chennai. Dr. Pankaj Ahire from Mumbai. Dr. Samir Kumta, plastic reconstructive surgeon. Dr. Nikita Sethi. So it is very much lined up. All the programs are there. And in the evening, there is a patellofemoral instability. There, we have another faculty, foreign faculty. Here, you can see that. Let me put the name of that faculties, introduce you for tomorrow's webinar. I think you can see the screen, nah, sir?
Yes, yes, we can.
Okay.
But
Okay. Now, tomorrow evening, Dr. Deepak Goyal is moderating, and we have a Professor John Falkershan from USA, Dr. Lutul Furro from Cleveland Clinic, Dr. Sundar Rajan from Coimbatore, Dr. Rahul from Dubai, Dr. Gurinder Bedi, Dr. Tanna sir. Many faculties are joining. Still, it is incomplete web page. So I am stopping the sharing. Maulin bhai, you can take over.
yeah, thank you very much.
Please. Kamlesh bhai, do you want to say one or two words while he's sharing?
Yes, very warm welcome all viewers and all faculties from different regions on behalf of Gujarat Orthopedic Association. Thank you very much. Thank you all faculties and viewers. Yeah, carry on, Molin bhai.
Yeah, thank you very much. So Navin bhai already has introduced, and this is all the key thing about this is these all are the key friends and the friends with the same mindset. And I chose them so that it will be a very straightforward and a great webinar. My local colleagues, Kamlesh and Dhiren bhai is always helpful. So let's start the ball rolling. Now, there are three sections of today's webinar. This one is proximal radius fractures. Other is acute Monteggia fracture dislocation, and we'll briefly also touch missed Monteggia fracture dislocation. Let's start with the proximal radial fractures. Now, we see this kind of X-ray and this completely toppled off radial head. Now, there are a lot of modalities of approaching this problem. And let me hear from the faculties, first of all, that what they think and what modality they would choose to treat this situation. And I'll ask Kapil, Kamlesh, and Atul and Dr. Thakkar their opinion about, in one line, what treatment they will choose for this patient. Yes, Kapil, what do you think about it?
Yeah, Molin, so this is a severely displaced and angulated neck radius fracture. And
sir, little louder, sir.
Okay, so this is a severely displaced and angulated radial neck fracture. And I think to manage it, the first thing will be to try and align it. So close reduction would be the first step. And
Yes.
Probably looking at the amount of displacement, it might not work always. So
Yes.
then percutaneous assisted reduction techniques probably would be my choice. Yeah.
Yes, Kamlesh, what do you think about it?
Yeah, same. I agree with Dr. Kapil. As initially, we'll try for a close reduction. If it will not align 100% or displacement is too high, then definitely I will take help of intrafocal pinning or KY or whatever. The same management close
Perfect.
reduction with assisted device to reduce it.
Perfect. Atul, do you have any difference of opinion, or you have the same thought process?
So I would also ask for a lateral view to
Yes.
see where the displacement is.
Yes. So lateral view is like right in the center.
Okay. No, so I would echo what Kapil has said. I would definitely try close reduction, and there are various techniques to go close reduction. And also
Perfect.
one can use an S-mark bandage.
Perfect.
I found that very useful sometimes for patients.
Right. And Dr. Thakkar, do you think do you agree with our faculty, or
this is metaphyseal fracture? I think Salter Harris type 2 with metaphyseal segment. It needs close reduction, and if it is stable, then it has to be splint, or if not reduced by close means, then it has to be reduced by some other percutaneous, joystick method. Or
perfect. So we see lots of we have different opinion, and there are different modalities of treating this fracture, like close reduction or if it fails, then percutaneous joystick assisted reduction, or sometimes many people also consider intramedullary nail assisted reduction, or what's known as Matizu technique, or open reduction. Now, just like all the fracture, radial neck fracture is also having a distinct classification, and which guides us to some extent that what treatment modality would be successful based on literature. I'll just take you through this classification quickly, where Jude type 1 is undisplaced or mild horizontal shift, but there is not much angulation. Jude 2 is less than 30 degrees angulation. Jude 3 is 30 and 60 degrees angulation, while Jude 4 is the most severe angulation, and the most severe Jude 4B is lying right on the side of the shaft. So now I'll like to ask Gaurav and Anirban and Dr. Bobby John that how this classification helps you in your decision making, or to explain to parents at the outset when you start this treatment. Yes, Gaurav, what do you think about this?
According to me, Judays 1 and Judays 2 are well under, I mean, can be managed conservatively, because the displacement is less than 30 degrees, whereas Judays 3 and 4 need some intervention. Most of the times with the maneuvers, Judays 3 can be managed with close reduction, but majorly Judays 4B and 4A require some kind of intervention. So I would be having, I can forecast and I can prognosticate the family that we might need some kind of an intervention in Judays 4, whereas
Perfect.
yeah.
So Anirban, what is your take on this? Anirban.
Yeah. Whenever we look at any classification, we want to see whether it can give us an idea about the severity of the disease, and whether it can give us any idea about the treatment algorithm. And the Jude classification gives us both. So it grades according to the severity, while it also gives us a plan that more than 30 degrees to 60 degrees angulation needs to be definitely restored.
Right.
And the aim of the treatment would be to try and convert a Jude 4 or Jude 3 to at least a Jude 2, so that you can get a useful range of motion back.
Perfect. Yes, Dr. Bobby, do you have any further comment to add on this?
I think just to summarize it, you're looking at a classification more as a therapeutic and a prognostic guide.
Right.
Where you're able to communicate with the family, because higher the grade, you also need to remember that there are, challenges or problems that might come up with these, including post-traumatic stiffness, restricted movements. And
right.
If, you really had to go in and do an open reduction, which you by and large want to avoid, the chances of a synostosis. So definitely with the type 4, you need to keep all that in mind.
Right.
Essentially, you're looking at therapeutic and prognosticating it.
Perfect.
For yourself and for the patient.
Perfect. So one more point is, when the Jude type 1 and 2, when less than 30 degrees angulation is there, we expect a good remodeling potential, and this remodeling will lead no rotational rotational problems later on. But as Dr. John said, as the angulation increases, the severity of injury increases, and that may lead due to more problems. So as Gaurav and Anirban said, type 1 and 2, we can treat them conservatively. Type 3, close reduction can be taken help of. But when it comes to type 4A and 4B, mostly along with close reduction, we might have to add percutaneous or in rare instances, open reduction. So now,
Or one more thing before you go on to the next. I think in addition to the angulation, I think the displacement is also important.
yes, so I'm just coming to that.
Okay.
That there's a nice paper in JBJS by John Wedge, and he said that you just don't look at the angulation, but also look at the translation. And he said that when translation is more than 2 millimeter, that reduction works as an cam effect, and it may restrict the rotation when it heals. Now, as this is restricting the terminal range of motion, probably we do not see great limitation, but translation is also the one thing which we should take in consideration. So translation should also be minimum. Now, I would inquire with other colleagues that when it comes to close reduction technique, Rudra, what maneuver you try to do to reduce a radial neck fracture? Rudra, and I'll ask Dr. Ved later on. Yes, Rudra. Rudra, are you with us?
Sorry, Maulin, please can you repeat it?
Yeah. So when you try to do a close reduction of radial neck fracture, what are your maneuvers?
Yeah. So the close reduction maneuver, what I generally do is in a semi-flex position, I do a good traction in the neutral position, and then I do in the traction, while the traction is on, I just do manipulate it in the radial head area with my other finger and just gently try to push the radius directing from posterior to anterior.
Right.
And then I pronate it. So
right.
This is what I do it. So this is the manipulation what I generally do.
Yeah. So Dr. Mida, do you have experience of reducing this radial neck fracture which are a bit more displaced? Dr. Ved?
Yes, what I do is I just under the image intensifier rotate the arm in such a way that it found the place where it is maximally angulated.
Perfect.
Now I know the plane of the angulation is now at right angles to my x-rays.
Right.
That's the time where I put my other finger while my other hand is putting a varus force onto it. With the other thumb, I push it into the place where it should be. And yes, I would say in half of the times I can succeed in reducing them without putting any percutaneous wires.
Perfect.
But it was heartening to know there are so many methods. I never knew there are so many methods described.
So there are so many methods described because although these all methods were successful in producing good anatomically acceptable reduction in Jude type 2 and 3, but when it comes to type 4 and 4B, none of these techniques are guaranteeing reduction.
That's right.
And
That's right.
for last few years in Ahmedabad, we have tried one close reduction technique, and in a sequential patients, around 15 patients, we were successful in reducing all type 4As and 4B to complete anatomic reduction. So with this platform, I would like to share with this technique what we do. And this is an animation. So as you said, we try to bring the radial head in a way, we rotate the forearm under image intensifier in a way so that we can see the radial head in a profile, and radial head looks like a rectangular piece. And this is the pre-injury position of the forearm. In this position, the assistant gives a varus force to decompress the radiocapitellar joint, and we as a surgeon have to give a longitudinal traction, and then you give your thumb pressure, and that will convert a Jude type 4 to type 3. And with this position, you simultaneously flex in pronation, and that flexion in pronation reduces or brings the radial head completely over the shaft of radius. And then you can check the range of motion, the stability in full range of flexion extension as well as in lateral view. So this technique does not require any implantation or K wiring, and you can just plaster them in pronation position, and we could achieve close reduction in almost all the patients. I'll repeat that animation for all of us again. So we rotate the forearm so that we can see the profile of radial head in AP view. We should see a rectangular piece of radial head. And then in this position, we ask assistant to give a varus pressure, varus thrust to decompress the lateral side. And the surgeon gives longitudinal traction. And with a thumb, he presses over the radial head. And with this manual pressure, we can reduce partially. And with this continuous flexion and simultaneous pronation locks the radial head with the distal fragment. And in this position, we can flex and extend, keeping the forearm in pronation. And you can see the reduction completely. And you don't need to fix them, just give them plaster in that position. So there is biomechanical basis of this technique. When we supinate the forearm, it relaxes the annular ligament, radial collateral ligament, and ulnar lateral collateral ligament. And so the lateral recess remains open. The moment you flex and pronate, these all ligaments becomes tight, and those Jude type 2 radial head sits into the place, and that makes this reduction possible. So if I just show you on patient, this is the traction of elbow extension in pre-fractured position, and the varus stress given by the assistant, and you give now thumb pressure on the radial head, confirm that this is partially reducing, and you flex and pronate the forearm, and you apply plaster in that position in mid pronoun and 90 degree of elbow flexion. Now this is the same patient which we're talking about, and this is the AP view. And once we gave varus thrust and some thumb pressure, we could convert a type 4 to type 2. And once we applied the plaster, the radial head was completely reduced in pronation. So this is how we can reduce this completely displaced or topple radial head. And this is final 1 year follow-up. So you can see these patients, most of the patients have full range of motion. And now this paper will soon come in Indian Journal of Orthopedics. So the key thing which we have found is we should have some less threshold. You have to try once or twice. Many a times when you attempt once, you may not be successful, but you try a couple of times and you will be successful. Secondly, the most important thing is your thumb should be on the radial head. Many a times we just see the AP view and we do not know where the radial head is lying anteriorly or posteriorly. So you have to locate the radial head properly, and that technique will help. So I wish all the faculty and the colleagues should try, and that helps a lot. Yes, Navin bhai, any comment on this, Atul, this technique or your experience? Any one of you have experienced this? Yes, Mandar, your comment.
Yeah, so to be frank, I have tried in a couple of patients, but as you said, it was, I had a very low threshold for converting into something which I'm more familiar with. However, what is very important is, as you said, is that what we have to remember that a radial neck fracture is a valgus injury. So the reduction is going to happen with some amount of traction with the varus force to the radial head. So that is something which we need to understand when we are attempting any means of close reduction, right? May it be the Eschmark bandage or the orthokids technique or any technique. Basically, the reduction has to be in some amount of varus with some traction.
Some traction, agree. Yes. Any other comment from any other faculty?
Who says two genius can't think same? Means I've been doing this method quite a long time, but it was nice to see how supination, pronation can make a difference. That's new thing I've learned. I will definitely use that.
Because supination, if you do any open reduction also, you see that supination will make the radial head loose. The moment you pronate, you will see the reduction is happening.
Yeah, that's a new learning for me. Yeah, thanks.
Fine. So let's yes, Atul.
See, sometimes when there's a lot of swelling, one trick I've tried is that you aspirate the hematoma.
So Atul, I'll come to that when we see and we'll come discuss in subsequent case. So let's see this case now. This is a 11-year-old girl where you can see this completely toppled off radial head and close reduction failed. So you are trying a lot. You have tried orthokids technique, and even I tried, and I could not achieve close reduction. Now I like to know from the faculty that what will be your next step. Mandar, I'll ask you first, then Rudra, and finally Dr. Thakkar. that if you tried close reduction, but it is not coming, what would be your next step? Mandar, please.
Yeah, so typically when I see such a kid, I'll try to attempt close reduction, but many a times it doesn't work as well as it should. So I'll go for a combination of an intramedullary with an intrafocal reduction. So what I usually do is I start off putting the nail till just distal to the fracture site through the distal radius, and then
Which
use a
nail
small.
you use, Mandar? You use a titanium nail or a
Yes, so
simple
I
SS wire?
use, yeah, so I use a titanium elastic nail because I usually feel that hockey helps in manipulating it later on.
Okay.
That hockey bend helps
So
in
I think
manipulating.
we should discuss that in Matezu part. Yeah, please go
Yeah.
ahead.
And then once the wire is just distal to the fracture site, then I use a small, I use a 2 millimeter wire with the forearm in some amount of pronation, and try to hitch that radial neck in from a Jude 4B to a Jude 3.
So you use a wire as a leverage to
As the
reduce that
leverage.
head, and then you
Correct.
use intramedullary.
Intramedullary,
Perfect. So
and
it's a
then reduce.
combination of intrafocal
Correct,
and
correct.
Matezu.
And a
Yes,
metazo.
Rudra Prasad. Rudra, what do you do?
Yeah, more or less the same thing what Mandar was talking. I think we have to convert this Jude 4 to 3 so that the moment you reduce that either by your thumb pressure or even as some kind of a blunt instrument from outside while you're giving a traction with varus, and then if that reduces, the fixation would be definitely from an intramedullary wire, because the child is quite old child, in the sense 11-year-old child. I think that will be a good option, so that you can achieve a good reduction and also maintain with the tense nailing. I also use the tense nail.
Perfect.
So on one wire and to CM guidance should do the job.
Yes, Dr. Thakkar, do you do anything differently? You just use intrafocal pinning, or you also do the same thing?
Yeah, definitely, because more than 10-year age of child, that's definitely a vast problem. So it has to be reduced with the focal, with the joystick,
Focal
or it
pinning
should
joystick.
be,
Okay.
yeah.
So I'll ask any of faculty who is using only intrafocal pinning and not the Matezu. Any faculty?
Yes, Molin bhai.
Yeah, it
Yes,
can be
Kamlesh.
managed.
Kamlesh,
Yeah.
what is your opinion?
See, I'm very familiar with intrafocal pinning. So we'll
Okay.
do a reduction. Then if it is stable in flexion and extension arc, so there is no need to put any fixation. But already you know that it's a very stable variety. So I particularly, and if it is not stable, then we'll fix the same K wire or another K wire. So
Okay.
I'm
So
happy with
Kamlesh is of
yeah.
opinion that he loves intrafocal pinning only, and he checks the stability.
Yeah.
And some of them are thinking that, so let us take the intrafocal pinning as first, and then we'll go on the intramedullary nailing. So when we are using this intrafocal planning, there are a few questions come to mind of general colleagues, orthopedic colleagues, that whether you use a sharp or blunt K wire. Kapil, I'm asking to you, because sharp K wire, if it goes haywire, you may injure the posterior intraosseous nerve. Kapil, what sort of wire you would like to use?
So, Molin, I use a sharp-tipped K wire typically, and I'll use a 2 millimeter wire. So I want the wire to be stout, because when I'm trying to lever the fragment up, if it's a thin K wire, sometimes it bends, and then you have to reinsert the wire, which is something you don't want to poke the elbow again and again. So I use a sharp tip typically, and I try and go in the fracture site to try and lever.
Okay. The next question comes to mind, like whether the wiring when we do, is it intrafocal or kind of head engaging and pushing? Because there are some literature showing that you should not pass through the fracture side, because there is a very
Small
trivial
blood
blood
vessel.
supply and it may produce AVN. So I will ask Atul, whenever you do your combined intrafocal and Matezu, whether you go through the fracture site or you do engage the head. Atul.
No, I try and engage the head,
Okay.
and then try and lever the head back into position. Sometimes when there's a lot of swelling, I will aspirate the hematoma and just make a skin incision and do a transcapsular reduction. And that is also,
So by meaning engaging the head means you use a sharp wire and put it into the cartilage and then push with it, or you use a blunt wire. You use a sharp wire, but you don't go through the fracture, but you engage the cartilageous part of head lateral. Okay. Dr. Bobby, what is your opinion on this? Bobby
Look,
John?
my take on this is that, look, as long as the periosteum is not disturbed, I don't think that should be an issue with regard to the AVN. I mean, I would use a sharp wire to
Right.
do an intrafocal leverage and get it reduced and leave the wire across the opposite cortex.
Perfect. So that's a correct technique has been described in few papers. Now the next question would come to our mind is once reduce and how to fix it. As Bobby said that he would pass the same wire through the opposite cortex of distal fragment, and Mandar told that he uses this for reduction and then he would add into the kind of intramedullary nailing. Anyone who does fixation other than these techniques, two techniques, or the same
Yes.
technique?
Marlin, one point I want to tell you here
Yes,
is
Rudra.
if the age of the child, I think definitely is a consideration here. A Metasio technique will be better if the child is 7 or 8 years and above. Below that, probably a simple joystick maneuver to reduce it or intrafocal, whatever you use it. And then if it is stable, probably we don't have to put any wire. Just accept it and put the plaster. If it is unstable in a pronation and supination, probably yes, we may have to go ahead with the wire fixation.
I think an intrafocal pinning is so much more easier. Why would you want to, double the whole procedure by reducing it and then putting a wire from below?
Yeah, so the advantage, Dr. Bobby, advantage they're seeing is when you just put an intramedullary or metazu thing, sometimes you can start mobilizing a bit early. But let us discuss that in the metazu session. And I would like to ask what precautions you would take. This is because this is a meeting for general orthopedic surgeons. So if they are trying to do this technique, Atul, what suggestion you would give to them, or what precaution they should take while putting this wire?
Can I come in at the last point?
Yes, I'll come to you, Dr. Mida. Let Atul talk about what precaution, and I'll come to you.
So certainly one should not make multiple entry points. One should be clear about the nerve. You have to make sure you don't cross the wire and hit the ulna. Otherwise, the hematoma will cause a synostosis. And that's why it's the concept of aspirating the hematoma.
Right.
Avoid multiple punctures and avoid multiple attempts.
Right.
And like Rudra said, if it's stable, I will not put a wire at all. And
right.
For a mature technique, you need to have metaphyseal bone. Sometimes the sliver is so small, the J of the mature technique will not engage. So you must have good
so
metaphyseals.
that we'll discuss later. But there are two important points Atul told. Is there should not be multiple punctures so that you are devitalizing the blood supply. And secondly, we are going through capsules sometimes. So we should not also produce capsular fibrosis because that can lead to stiffness. Yes, Dr. Mida, what is your take on this?
Yeah, at the time, I want to intervene the previous stage, reduction.
Yes, please.
Yes, I always keep this metazu wire on my table, but I don't start with it. I usually try to reduce them first closely and then with the intralesional wire. And
once
I agree
you
that
reduce it and you check stability, if at all it is needed, then only you go for metazu.
Okay, that's right.
So that's also valid.
And I always prefer to fix this by passing my wire through the distal fragment, opposite distal cortex, as we do in a Colles fracture.
Right. So just like a Kapanji or a intrafocal pinning.
Yeah, Kapanji technique. Yeah.
So Kapil, any take on precautions you would like to add? Anything to Dr. Atul and what Dr. Mida said?
Yeah, Molin. So precaution-wise, when you pass the wire, then you want to pronate the forearm. So that kind of pushes the posterior, because actually what we are worried about is, other than the capsular and the fibrosis, is the posterior introosseous nerve, because you don't want to get a posterior introosseous nerve palsy later on. Right. So I would pronate the forearm and then try and get a high entry point for the wire so that you're away from the nerve as you can. And then once you have levered the fragment and got it in place, if you are wanting to fix it with the wire from the lateral aspect of the elbow, then I would probably use another wire to fix it and not use this wire, because when you put the traction, then you may inadvertently be causing a traction injury to the posterior introosseous nerve.
Perfect. So that's a great piece of advice. Now the question to
just a question.
Gaurav.
Just a question.
Yes.
What's the incidence of posterior introosseous palsy with this maneuver? I think we are putting overweight on the
Yeah.
potential injury
Yes.
to the.
So Anirban, do you want to say Anirban about
There are questions also. Similar type of questions are
so
coming from the
let
audience.
Navin bhai, let Anirban answer this about his
Then we'll
experience
take the
about.
questions.
Yeah,
Then
please.
question.
Yeah, yeah.
Yeah, I
Anirban.
think the direction in which we pass the wire is important. And in my early stages, I also have had a transient posterior interosseous nerve palsy when I tried the joystick technique, but it recovered uneventfully. The important thing is that since like Kapil mentioned, that you pronate the arm so that the nerve moves a little more anteriorly, and you enter in more from the posterolateral side, because posterolaterally is where the radial head is more commonly displaced. So you use your, you come in more posterolaterally, engage the head, and then gently turn it over. Now, both the methods, whether you use it as an intrafocal pin or an extrafocal pin, both are well documented, and you can use either one. But the important thing is, if you're using an intrafocal one, it has to be a slightly larger diameter because you are going to use it to lever it on.
Yeah.
Whereas if you're using it as the extrafocal pin, then it might be a slightly thinner diameter because you want to engage in it.
Right. So the young delegate should understand that posterior interosseous nerve lies anterior to the radial head. It doesn't lie posteriorly. And it is very easy to use this technique in the posterolateral displacement. And when it becomes an anterolateral displacement, which is a rare incidence, this technique becomes a bit difficult, and one can do a mini open to safeguard the nerve. Now I'll show you case example, and then Navin bhai will take the questions. So this is a completely toppled off fracture 90-degree, and we just pass a 2 millimeter sharp tip wire. Under IITV guidance, we go through the fracture site, and once we are adequately advanced in the fracture, we start levering or elevating the wire, and you can see the radial head is started reducing. And once you see that it is completely reduced, then you pass that wire to the opposite cortex. As Dr. Meeda said, it's kind of a Kapanji for proximal radius or intrafocal. This is a leverage technique, and you every time you confirm in lateral plane also that your wire is not going haywire or injuring anteriorly the neurovascular structures. And it's just single stitch, and we have done a lot of this intrafocal pinning, and we have not found much rotational problem or stiffness. So this can be done, but the newer technique, and we will talk just after this. Yes, Navin, by your questions from delegates.
Yeah. The one of the question was about this spin palsy.
Yeah.
Site of the entry of intrafocal nailing, taking care of the nerve injury.
Yeah. So
do you want to clarify
entry, as I mentioned, that the nerve passes anterior to the radial neck. So one has to take your wire from posterolateral side and not the anterolateral side, because anterolateral side the wire nerve would come. Any other question?
Okay.
Yeah.
Is there a possibility, Dr. Nitin Patil is asking, is there any possibility in unstable reduction your experience about capitular radial pin for 10 days?
So we will talk about it little later in the Montagia.
Okay.
When we are talking about isolated radial neck fractures, we are not talking about dislocations, and these are usually stable situation, and we need not pass radiocapitular wire. But we'll talk more about this in Montagia.
Okay.
Yes.
Okay. Dr. Jaswinder from Patna is asking chances of redisplacement after this technique in the plaster without fixation. When you have done a reduction and you have given a plaster only, what are how many incidents of redisplacement?
Yes, Atul, you want to answer this question?
So I don't think there's a figure to it, but it's very important. After you reduce the radial head, you check the pronation and supination.
Yeah.
If it is unstable, then you have to put a wire. If it's stable in pronation, supination, and then you can just put a cast.
Yeah.
Chances are it will stay there. So I would think the stability test is very important.
So what my experience has been is these reductions are more stable in pronation. So once you keep the forearm in mid prone and you just check in full range of flexion extension, both in AP and lateral plane, you give your plaster in mid prone or little bit more supination from mid prone, and this will not move. But you have to check. If you find there is any instability, you may add a pin or
can I add something?
Yeah.
Yes, please. Yes, please.
If the elbow is in 90-degree flexion and pronation, even if redisplacement occurs, it's not more than 10 degrees or 15. Usually it's not severe. So up to 30 degrees you can already accept. So displacements are usually less than that. and most of the times they are acceptable. So really you need not to
So you
worry,
Yes.
because there
So
is no valgus force being applied at that
so
time.
that is the that was the follow-up question by
Yes.
anonymous. How much valgus angulation is acceptable after the treatment in case when the fracture was irreducible?
So that is 30 degree, because
Same
30
Less
degree is
than
a
30.
number. Less than that is remodeled, can be remodeled.
And what the Molin Bhai has
But
said
if
is
it is in,
reiterated by Dr. Dayanidhi Desai. Full pronation to achieve reduction, then cast to be given in the mid pronation. That is a
Yeah,
reiteration of the fact
yeah,
which you have mentioned. Yeah.
with 90
right.
90 degree elbow, 90
90
degree
degree.
elbow.
So
Atul
let's
bhai,
move on, Naveen bhai, let's move ahead. And these are a few papers which I was talking about published in CORR and CCOT. And now let us talk about Matezu technique, which is very popular nowadays. And it was published right in the 1980s by Matezu. And Dr. Dhiren Bhai has a great experience in few cases. So this is a case by Dr. Dhiren Bhai. And there's a 9-year-old boy who was completely toppled of radial head, where close reduction probably didn't work much in isolation. So Dhiren Bhai, can you take us through your technique? What did you do?
Yes. So when we see such a patient, the 9-year-old boy with the almost 80-degree displacement or the angulation, and if you go to the next slide in a lateral view, yes, please back. So you can see that the end-on view of the head. So that says that it's 80 to 90-degree angulated. So now we have two issues with this technique. The first point is like we want to bring it to the range of less than 30, which is an acceptable range. And then the second question is like how to immobilize it or how to fix it. So both the things can be done with the Matthews technique. But first of all, let us understand that this fracture requires reduction. This is not an acceptable position, so we need to reduce it. Now, how much reduction we can get is a question, but first of all, we need to do something to reduce it. So we start with a non-invasive technique. There are various techniques. Nowadays, I prefer the technique which Maulin has suggested. And basically, the aim is to bring it to the less than 30-degree position, which is an acceptable position. So this is one technique which works well, and we should try to reduce in this position. So if you get like a position where it is very good, it's fine. If not, in that case, we need to go for a second technique, which is, I call it a joystick technique. This is different than the technique that's an intrafocal one. In intrafocal, you go inside the fracture gap. Here, we are trying to engage a sharp pin into the head radius. So we need a sharp pin, and that goes directly into the head radius. Next slide. So now, once we have achieved a position which is less than 30, fine. Then we really don't need to go to the Matthews technique because it's an acceptable position. But let's talk of a situation where you are between 30 to 60. So now you need a better position because this is not an acceptable situation. You have tried both the method, that is joystick as well as the close reduction. So now we rely fully on Matthews technique for the purpose of getting a reduction. For that, the first point is like we need to take an entry from the distal radius, and usually entry can be from the styloid process or from the dorsal side. Either way, it depends on your preference, but we need to pass either a 10 nail or a sharp K wire. It depends on the affordability of the patient. The sharp K wire has an advantage that it can penetrate into the hard bone of the head radius. The 10 nail has an advantage that it's more being a flexible. You can negotiate the head radius very easily. So once you bring your tip of the wire or the nail at the fracture site, now you have to give a sharp blow so that your tip of the nail enter into the head segment. That's the most important thing, that you give a sharp blow. At the same time, you apply a counter pressure so that there is no further displacement. So once you have an entry, now the most important crux of the Matthews technique comes. To understand that, let's see what we are talking of. We are looking at the end-on view, means we are looking from the top. So what we see is a olecranon or a ulna. Then the blue one is the head radius, and the other circle which we see is the shaft radius. we can see that the head radius is posterolateral in relation with the shaft, and we want to bring it to the center, to its normal position. So once we have the sharp tip of the nail inside the head radius, usually the head radius is lying posterolaterally, so we have to adjust our tip posterolaterally, and after that we rotate so that the tip comes towards anteriorly and then towards the medial side. So when we rotate along with the nail, the head radius segments come to its position. So this is what we need to do in this Matthews technique. So once we have achieved a reduction, the next point is like we can remove the wire, but because we have already engaged the already we have fixed it, so we can use the same implant as a fixation device, and we can continue without immobilization. That is what the original paper says. I don't have that much courage, so usually I give 3 weeks of simple slab or a plaster immobilization, and this is what the result is. So this is in nutshell about the Matthews technique. So we use a wire for reduction as well as for fixation.
Yes, perfect explanation, Dhiren bhai. Now, few questions would come, I'm sure, to the delegates' mind and even to our colleagues, that where to keep the tip of nail, inside or outside the skin. Now, this question arises because as there is very small proximal fragment, when you hammer the nail, you do not have control that how much of part would you keep outside. So do you keep the tip of nail outside or you bury within the skin, and how you do it?
Okay, fine. Yeah, so I keep the tip of the nail, that's a distal end of the nail, outside the skin. The only advantage of that is like it can be removed easily as a OPD procedure without anesthesia. If you bury it, the advantage are that you don't really need to worry about the skin infection. But for that, we require a small procedure, or like we need anesthesia, and then we need to remove it.
So
So
when you
either way,
remove it,
it works well.
after how many weeks you remove this nail?
3 to 4 weeks. 3 to 4 weeks.
And can you remove this on OPD basis? Isn't it painful for child?
No, if we have kept the tip of the nail outside, yes, we can remove it, but it all depends on the temperament of a child. It all depends on the temperament of child. I am not very, like, I have given anesthesia also for removal, and I have done it without anesthesia also.
Right. Yes, Mandar, what is your take? Whether if you keep the tip nail inside, outside, how you manage that fine few millimeters of nail? You are mute. Mandar, you are mute. Please on your mic, please.
Yeah. So typically, as you said, if it's a shaft radius, we have some space for us to hammer it after we have cut the nail. But here we don't have that advantage. So what I typically do is I bend the nail slightly, so that then it doesn't impale on the tendons, and I cut it as close to just under the skin as possible. So I always keep it under the skin, but the tendons should slide on both sides of the nail, so that there are no
nail
tendon
tip should be more
pointing
superficial than the
so
tendons. Yes.
We are not going to keep this nail for a long time. This is going to be a much shorter duration of nail inside rather than a shaft radius or something.
So when you remove the nail,
so I take him under short GA and probably do a small incision and remove
after how many weeks? 4, 6, 8, 12?
I think about 8 to 12 weeks, depending on the union.
Okay.
Once it is inside the skin, I am not very scared of infection. So probably even if a longer period of nail inside, I don't mind. He can come whenever he has school holidays or something of that sort.
So Anirban, do you have any different methodology than this, or you follow the same thing? Anirban.
Yeah, I follow more or less the same thing which Mandar said. I ensure that the nail I keep it buried inside, and I remove it at a later date as per convenience. It's at least 3 months or so. One other thing which I found is sometimes in the slightly younger children, the minimum size of the 2 millimeter nail may not be, maybe also too large for the Indian population. So like Dr. Dhiren has shown, that you can actually use a 1.8 millimeter, those long Elizarov K wires or any long K wire, cut the tip, but I prefer to keep it the tip as a blunt tip, give it a 30-degree bend, like recreating the J of the tense nail. I don't use a sharp edged nail.
Okay. The question is how early mobilization can be started with Matezu technique.
Okay.
You start
Do
right
you want
away.
me to answer that?
I'm asking to Anirban and then I'll come to you, Dhiren bhai.
Okay.
So you told that after 2 or 3 weeks you start. Anirban, do you start right away or you also wait for 2-3 weeks?
I just wait for a week or 10 days, call them back, keep them in a slab just to ensure that they take a little bit of rest. Once the incision line for the nail entry point is healed, I allow them to move freely.
Yes, Dhiren bhai, how early you mobilize?
Yeah, 3 weeks onwards we can start mobilization. The original paper says that you can start mobilization right away, but as I said that I really don't want to be too aggressive because range of motion is never an issue in this fracture.
So Mandar, what is your take on that?
Yeah, I usually keep for about 2 to 3 weeks a plaster, just for some healing and some rest and some decrease in swelling. And at around 3 weeks or so, I start mobilization.
Why I'm asking this question is that one of the indication is that when we compare it with intrafocal pinning, in intrafocal pinning also we have to wait for 3 to 4 weeks and then to remove the wire and start mobilization. So looking at your approach, there is not much difference between the beginning point of the exercise. The question to other faculties like Atul or Dr. Ved, what precautions or have you any bad experience with Matezu technique? Or is it all rosy or sometimes you are not able to perform it as you wanted? Yes, Atul, what do you say?
So I've seen a couple of complications where the nail has actually entered the joint.
Okay.
And it's because when you hammer the nail in the end, there's a very thin metaphyseal component. That's a silver.
Right.
Then this technique may not work very well. You need to have a good metaphysis which will engage the nail and help it rotate.
Right.
One has to ensure you can see it in all planes. So before you put the plaster, you will ensure that the tip is not penetrating the joint.
Right. So that's one message, that when you are hammering also, you have to look into that it's not penetrating the joint. Yeah. Any other comment from faculty? Yes, Ved, Dr. Ved.
Yes. Regarding sharp or blunt wires, I try to put the Elizaro wire sharp because I think the grip on the metaphysis is better with a sharp wire. So your rotation doesn't lose the grip. If it is a blunt wire, once you rotate the wire to get the head into position, you can find the wire rotating inside the head and creating a cavity rather than carrying the head along with it.
So it's a fine balance, you want to use a sharp wire, so have good engagement. At the other side, you don't want to penetrate the joint. So that's an important
second
point.
Yes, that sharp wire has the disadvantage that it can penetrate the articular cartilage and enter the radiocapitular joint. So you have to be careful about it.
Right.
Third, hammering in the end is probably not advised. I think hammering it can go into it, or you can really change the things for worse. Means it can rotate while hammering and redisplace the fracture. So cut it under the cut it under the skin and leave it there. I usually put a plaster slab for 4 weeks and take the wires out and the plaster out at the same time.
So I agree. I agree with all of you, and there are proponent of both the techniques, like me and Kamlesh and some other. They like to do intrafocal, and there are people from Matezu. Now we try to bring you the important points and tips and tricks while you perform this technique. The key point is we have to bring more than 30-degree angulation to less than 30-degree, where it has a good remodeling potential, and so the child would not have any rotational problem of there won't be any restriction of forearm pronosupination. Now let us go to another situation, and this is a paper. There's only one paper I found where they compared elastic nailing and percutaneous pinning. Now this paper is from Italy, and this is probably from the same institute. So they say that in 25% who had a patient who had intrafocal pinning had some restriction of pronosupination and radial head enlargement, and there is no complication with ESIN, but there is but the faculty thinks in a different way. So this is one paper which you can go from Journal of Orthopedic Trauma 2013, which compares this two technique.
Is it intralesional?
Do we have any question about this?
Intralesional wiring or simple wiring?
Intramedullary. This is just same as Matezu technique.
Percutaneous pinning, is it intralesional wire or putting a wire across the fracture site?
No, it is leverage technique. So intralesional wire, yeah.
Okay.
So Naveen bhai, can we go ahead, or do you have any
Yeah.
questions?
There are questions. There are questions.
Yeah, please ask
The
her.
first
Any
question is from
sorry.
Vijayawada. Dr.
Yeah,
Adapalli Srinivas Rao is
yeah,
asking for your technique. What are the
yes.
chances of pin palsy with your technique, Molin's technique?
Oh, we have never seen a PI and palsy because this is a closed reduction technique, and in closed reduction technique you cannot give pressure on the posterior interosseous nerve. Secondly, we rely on the integrity of all the ligaments. These are the situation where there is no associated elbow dislocation. So our radial head is quite well covered, and in last 15-20 cases where we have never seen a PI and palsy.
Okay, the next question from the Dr. S. Rawat is, what is the diameter of the tens usually you use?
Yes, Dhiren bhai, you would like to
Dhiren
answer
bhai.
this question?
Yes, it's a 2 millimeter.
Molin bhai, temporarily I'm sharing the screen because somebody has sent Dr. Dayanidhi has sent the X-ray to open. So
Yeah, please.
automatically your screen will be stopped, and once you start, it will automatically start from this slide only.
Perfect, no problem.
Okay, Dhiren bhai, go ahead.
Yeah, so basically 2 millimeter elastic nail.
Yeah,
Ten.
any
2
other
mm.
opinion? As Anirban said, sometimes you have to decide based on what is the canal diameter, and you might use a smaller wire. That 10 snail is appearing in all the diameter. Someone can use SS wire also. The key thing
Actually,
is
the
the band which you give should not get straightened by the time you reach the proximal fragment.
yeah, the 10 snail is available in 1.5 mm size also, the synthesis originally, but that size is not really available in India. So
Yeah.
the closest that you can get to less than 2 is the 1.8 millimeter Elizra of K wire. It's long also in size, so it serves the purpose.
Right.
Okay. I can
Yes.
give an input. I have made a flexible wires with the stainless steel, which are much more flexible than the titanium elastic nail, and it's available 1.5 mm, but no, still not marketed. So
So you
we are
better
doing
start.
that. We are doing with the flexible nails, right?
At the
And
end
now
of
the
this
question
webinar.
again the question from the Dr. Prakash Chauhan.
Yeah.
He's a pediatric orthopedic surgeon. 7 years female, 2 months old radial neck with 80-degree displacement. What should we do?
Yes, Kapil, what would you do in this situation? And then Bobby John would answer this question. 7-year-old female, 2 months old radial neck. It's a neglected kind of. Yeah, Kapil.
Yeah, that's a difficult one actually, because 2 months out, probably it's not going to budge on any close reduction. It's probably solidly healed. Actually, most of the reports on radial neck fractures, the healing time is about 2 to 3 months from injury. So, depending on what's the amount of disability, what's the amount of rotation, I would have to take a call. And if the rotation is not severely restricted, I would probably give a chance to this child to just mobilize and get the movement back, because
Right.
to get that fracture in place, it's probably going to require an open reduction and a re-osteotomy and fixation, which is a big undertaking and full of
Right.
complications other than that.
Yeah. So we have to say to the parents at the outset that there is a chance that it may become a bit stiffer, and this is not a in Gujarati we say Kolsani Dalali, Prakash. So that's like that. Yes, Navin bhai, can you share other
Okay,
case?
So my take on this.
Dr. Dayanidhi Desai sir has shared these pictures. Can you see
Oh,
this picture very well?
yes.
Yeah.
Yes,
Yes,
sir.
yeah.
Yes.
This seems to be an old fracture with displacement, and it has partly healed, and there is avascular necrosis kind of picture of the radial head with cubitus valgus. So Bobby, would you like to take this case?
Sure.
How do you approach this case? How old is the injury, Navin bhai?
Let me check in the text part of the message, because
I thought that this is Prakash's case.
no. It
Oh,
is
okay, this is
Dr.
Dr. Dayanidhi's case.
Dayanidhi Desai sir. Patient
Yeah.
is not happy with deformity. 15 years percutaneous joystick was done with 100% reduction. This is the position after 9 months. What is the management?
Okay.
No
So,
opening on the varus force, full range of movement, but patient is not happy.
Yes.
you know, beyond about a week, honestly, you're dealing with a late fracture neck of the radius.
No, it was reduced 100%, and then it got displaced.
Fair
That is
enough.
the case.
Fair enough.
Yeah.
So anything beyond a week, you're dealing with a late fracture neck of the radius. And there, I wouldn't really try and aggressively try to reduce it at that point. I'll wait for the fracture to remodel itself. Left alone, it would cause osteoarthritis of the radiocapsular joint. So, one of the options that is mentioned is to do osteotomy through the neck, an open osteotomy through the neck, and then you use your intramedullary nail to hold it in place. Having said this, it is an incomplete osteotomy where you don't disturb the periosteum on the other side. But you also need to warn the parents of the possibility of all these complications that you talked of, including stiffness and avascular necrosis. And in fact, this is reported in literature with good results.
Right. So the reason of why this has gone this way, it might be at day one, this must be very severe injury. And by trying to put it, the intrafocal pin, they might have injured the small residual vulnerable vessel. So this is post-AVN non-union. And usually we see this kind of global AVN with loss of metaphysis. And these are challenging issues. And as Bobby said, that you can do the intralesional osteotomy. And when if the child is skeletally mature, then
Now you can
sometimes
share. Now you can share.
yeah,
You
sometimes
share it. So
excision of
yeah.
the fragment also helps. So let's
and exclude infection of the
yes. So let's
radiocapitular joint.
we have a lot of cases to discuss. Let's go ahead with the next case. The one point about open reduction, we have a lot of papers which shows that what happens when we do open reduction for radial neck fractures. And this study shows that 90% of radial head enlargement, so there is some degrees of avascular necrosis. 35% patients have premature physeal closure leading to residual neck deformity, and 8% has gross AVN. So that's the reason why we all faculty would like to be away from the open reduction of radial neck. Now let's see another situation. This 10 years old girl was actually referred from Ethiopia, and there they tried a couple of reduction attempts, but it failed, and they came to us, and I tried to bring the radial head in profile. And what I found on IITV is the elbow is dislocating on extension. So now this is a problem situation. And you can see this, what happens. See, on extension, it is getting dislocated. On flexion, it's getting relocated. But here, I was not able to move the radial head much. So my question is to Gaurav. Gaurav, what problems can we anticipate for reduction of this fracture by applying our technique? Will it be successful? What do you forecast?
So any close reduction maneuver needs ligamentotaxis, and since we can see that the elbow is dislocating, so I don't think any kind of close reduction will be able to reduce this, and we might need some kind of a intervention in form of an open reduction or a close reduction or a intrafocal pinning to reduce it.
Right. So this brings us to a problem which is different than what we have discussed so far. So this is a radial neck fracture with elbow dislocation, and this is not an isolated radial neck fracture. So the first question which would come to our mind, and that I would like to ask, that can we clinically differentiate a simple fracture and a fracture associated with dislocation? Yes, Mandar.
Yeah. So many a times it is a diagnosis of retrospect, but many in the 2 or 3 cases where I have found a radial neck with an elbow dislocation, usually what happens is that there is a significant amount of contusion which is there around the elbow, especially a global contusion around the posterior aspect as well as the medial aspect, which shows the impact of injury which was much more than a simple radial neck fracture. The other thing is on the X-ray, on the lateral view, you can see that the radial head is slightly anterior rather than in line with the radial shaft on the lateral view. So as you can see that on the lateral view there is
the
a
more
slight
common
anterior.
is a posterolateral displacement. Here is an anterior displacement.
Correct. So that shows that there is something else which is going on, which we need to look at.
Is it a pediatric equivalent of terrible triad?
Yes.
So there is no coronoid fracture, but yes,
most
it
of the
is.
coronoid will be cartilaginous here.
Yes. So that is a possibility here. So now this entity has been very nicely described by Jeffrey in 1972, and he has described two entities like Jeffrey type 1 dislocation with radial neck fracture. I'm thankful to Mandar who gave this nice animation. He learned something from Dhiren Bhai, I suppose.
Yeah.
So this is what happens, that there is anterior dislocation, and with dislocation the radial growth plate is also injured, and there's radial neck goes anterior, and once the elbow dislocation reduces spontaneously, it leaves behind the radial head sitting in the front. So as a general orthopedic surgeon, we all should recognize that when we see this radial head fragment is lying anteriorly and not posterolateral, which we see in the routine valgus injury, this can be associated with an elbow dislocation. Another thing is, as Mandar said, when we see an isolated radial neck fracture, there is swelling and pain only on the lateral border of joint, but in elbow dislocation, there is a global swelling and contusion. The another type of Jeffrey type 2 is a posterior dislocation, and when it tries to reduce spontaneously, it takes away the radial head with it, and the radial head lies posteriorly. And sometimes we see this as an iatrogenic injury. This patient was referred to us with a posterior where someone tried an reduction in emergency, a general orthopedic colleague who tried and pulled their elbow. The elbow got reduced, but the radial neck got fractured. So sometimes Jeffrey type 2 is an iatrogenic injury also. So the question we already discussed, this next question is, what advice, Rudra, you would give to your orthopedic colleagues when you reduce elbow dislocations in children? Is it the same as we do in adults, or it is something different? Yes, Rudra Prasad.
Yeah, I think the important thing is to examine soon after the reduction is achieved if the elbow is stable or not, especially giving a varus and valgus thrust. So that's what is very important. And and then you have to produce all the kind of provocative maneuvers to see whether it is stable or not. And then of course you can make out the situations what you explained. One of the entrapment of the fragment in one of the areas. So those things have to be kept in mind. So it is the examination which is most important soon after the reduction of elbow.
So what is the practice, Rudra, you follow at your center? Do you reduce elbow dislocations in children under GA, or you do in OPD basis?
No. It's always under GA. We never reduce it in OPD patients. First of all, it's very painful and these children are very apprehensive and a lot of spasm. I don't think so. It's a advisable thing to do in an outpatient. So
Right, and unlike in adults, we have this growth plates and vulnerable radial head, so it can lead to dislocation. Now, Anirban, this question for you: what outcome in terms of elbow and forearm motion can be expected in this group of patient? Elbow dislocation with radial neck fracture.
Well, like Rudra said, that this can be considered as the pediatric equivalent of a terrible triad. It means that this is a much more global injury to the elbow as compared to a simple isolated radial neck fracture. Now, the moment you have a situation that the elbow is dislocated, you are in a catch-22 sort of situation. You want the elbow to stiffen up, so you would want to give them a reasonable amount of rest to allow the ligaments to heal. But that amount of, if you give them rest for up to 6 weeks, then you definitely would end up getting the elbow stiff. So this sort of injury, I would always prognosticate the parents that it was not going to be just a simple radial neck fracture, and that a restriction of movement of the elbow, both in the flexion extension arc as well as in the pronosupination arc, is to be expected rather than, and to be the rule rather than the exception.
Exactly. So coming back to our case, and in retrospect, if we see, this is a Jeffrey type 1 injury, as Mandar mentioned, and we could not reduce it by closed mean, and it required an open reduction, and it did that well, but there was some limitation of range of motion at the follow-up. So take home message for this is, for radial neck fracture, I would like to bring it to notice to delegates that isolated radial neck fracture and one with elbow dislocation behave differently. and that is our duty to tell the parents at the outset that they might need open reduction, and post-operative stiffness, as Anirban said, is a constant rule. And clinical examination, as Rudra mentioned, before the surgery is key. So with this, we are concluding the radial neck part, and I thank all the faculties for nicely contributing. And now we are jumping on the acute Monteggia fracture dislocation. Naveen bhai, is there any question regarding elbow fracture with radial neck, or we can
Yes,
go ahead?
yes. There are questions. There are questions.
Yeah,
Let me announce that we started with 2689, then it went to 3452, and now it is 3926. Participants
delegates.
are there. And
Great.
then in the radial neck fracture, does the oblique K-wire technique has much superiority as compared to the transarticular K-wiring in terms of stability? And what are the landmarks?
So we do not use trans-articular wires, and probably the delegate is asking that you are engaging the head and
Yeah,
pushing it. So there
yeah.
is no study which has compared these two techniques. That which technique is better? I would ask any faculty have any knowledge about any report which have compared a leverage technique to the engage head engaging technique. I don't think we have any report, Naveen bhai. Please go ahead with another question.
Okay. The another is Dr. Praveen is asking. I want to post one interesting X-ray. How to post? So to suggest him, you can post me on the WhatsApp. We'll try to include it. And another question from Dr. Maipat Singh Parmar.
Yes.
In 2 month old male united fracture neck radius, can we remove the radial head like what we had done in the adults? He's comparing with the adults of removal of the excision of the radial head.
Yes. So Atul, can you answer that question?
So I have done renal excision in a child more than 8 years. So we had a similar child who came almost 4 months post injury, and I have his follow up, and he's had no problem. So more than 8 years, it is you can actually exercise the radial head.
So
So
cutoff line is 8 years.
anyone in the faculty who
Yeah.
has done radial neck osteotomy? Yes, Mandar. Any experience with
Yeah,
radial neck
so
osteotomy?
not about radial neck osteotomy. I'll probably be slightly more conservative till about 12 years of age. Because there has been reports of cubitus valgus which occur after early excision of the radial head. Radial neck osteotomy again can be attempted, but we don't know how much of range of motion or any gain can be there after we do a radial neck osteotomy.
Yeah. So excising the radial head very early can lead to cubitus valgus and tardy ulnar kind of issues later on. And if we can wait and there is a bit glitch, that it may end up in early osteoarthritis. So it's a difficult situation. Yes, Naveen, any
Okay.
further, any
What
question?
was the case? Hello, what was the case in which we removed the head? Most of the times, neck fractures, head fractures in children are almost unknown.
Unknown, yeah. So I think excision was done in a malunited and severely displaced radial neck fracture with non-union probably.
Probably, yes.
Atul, that is your, you have to answer that question.
That child had AVN and a lot of stiffness in pronation supination, but very good flexion extension arc. So I actually exercised his head, and he regained almost 50%. He never regained full motion, but at least 50% of motion he regained.
So many times when the radial head is lying completely outside the joint, it makes things very stiff. But if you happen to reduce it, it gives good range of motion. And you can wait till the skeletal maturity. If it is producing problem, you can exercise it at that time and not very at a young age. Yes, Naveen bhai, question?
In a case with, excuse me, just this.
Yeah.
In a case
Yeah.
of AVN head, what's the usual range of motion you can expect to get even without excising the head? Did you gain this range of motion because you excised it, or you would have had it even if you had not?
So under anesthesia, the child didn't have any range.
No, with time, I'm talking about with time, he could have regained this range of motion even if you had not excised. Means, is there any chance my hypothesis is right?
Possible, but these are actually very rare cases we get in practice.
Yes, let's go ahead with other question. We have a lot of things to cover.
Any association of posteromedial ligament complex injury being a valgus injury in radial neck fracture?
Yes, so
Posteromedial ligament complex injury associated with radial neck fracture.
So these are very severe injuries, and along with radial neck fracture, we have seen sometimes posteromedial ligamentous tear. But we try to fix the bones, and then we give immobilize them for 4 to 6 weeks. And most of the times that ligament instability which we see in adult counterpart, we don't see in children. So there are very few reports of where people have required to restructure or reconstruct ligaments.
Yeah.
So
Yes, Mandar, your opinion
Yeah.
on this?
I think a general rule is that in kids, ligaments are stronger than bones and physis. So typically we don't have ligamentous injury in, especially in very young kids. What can be there when there is an association of increased valgus thrust which happens is that there can be a medial epicondylar fracture. So medial epicondyle fractures with radial neck fractures are known. So that can be equated to a medial ligamentous injury, which sometimes requires fixation.
Yes, Naveen, by any
the
further question?
question is, what, sir, you did in addition to the elbow dislocation in this case? Any additional procedure done in elbow dislocation case?
No, we just did an open reduction. What I found that the close reduction was not achievable. Anytime I try to do maneuver, the elbow would get dislocated. So the moment we reduce the radial head in its position, again elbow used to dislocate. So you have to reduce the radial head and fix it. So once the radial head becomes stable, then only elbow will remain stable. So that's what we did. We reduced the radial head, and reduction is not only necessary. I mean, is complete. You have to fix it. It should not move in the post-operative period. Otherwise, the elbow can get dislocated. So you have to fix it.
Maulin, there is
Yes,
another
Rudra.
point to be. Another
Yes.
point needs to be stressed for the general orthopods is there is no role for any radiocapitellar wire. Many
Yes,
times
so
this fracture
yeah.
displaced, or especially with the elbow
Yeah.
subluxations, many people think that they can do a stabilization with the wire which is
So
going from the
we are
capitulum
going
to
to
radius.
discuss that in Montegia, Rudra. We'll discuss
Yeah,
that part in
yeah, but
Montegia also.
you are right. There is a one orthopedic surgeon. He has said his experience of 30 years back. He did a transcondylar K wire in 10 years old child. That he has written already.
Yeah. So
Said his
what?
experience.
Yes. So Rudra, what you want to say about what are the complications? Let's take that question now. What complications can take place, Rudra? Please.
So the very common complication is the elbow stiffness.
Right.
Bad stiffness can result in, and even flexion and the rotation, especially the radial rotations can be lost. Pronation, supination restrictions can be really troublesome. So as the previous case which was shown by somebody, the very well fixed fracture but went into non-union, avascular necrosis, or synostosis, whatever. So these are the problems. Very well looking X-ray, but then the problems later, which starts with the stiffness and other things. So these things has to be remembered and can be avoided.
Yes, Kamlesh. Do you what do you
Invisible
forecast?
injury at the time of injury and injury done by the surgeon. Do you want to say like that? It is an
Sorry?
invisible injury.
Yeah, exactly.
So
That's the
that
way
is
to say.
so in any time when we put a transarticular wire, the children are notorious, and even though you give plaster, there is some range of motion. They are destroying the articular surface. So Kamlesh, do you have you seen or contemplated any complication by passing radiocapitellar wire, Kamlesh?
Yeah, I think wire breakage. I have seen one case. Wire breakage is very common because it's in plaster there are loosening and there is involuntary movements and movement is there, subtle movements in it breakage. It's very
Breakage
difficult
and
to remove that K wires.
this
And it's
wire may come out sometimes
Dr.
even
particular.
through the
Thakkar.
plaster.
So yes, what do you suggest?
This
So this wire
wire
may
may
come out. Yeah.
come out. Yeah.
Remember,
So
Anirban had a case where he has placed he saw a wire was in position, but still radial head was out. So that the hold of wire may be a problem.
yeah.
There is
Yes, Naveen bhai.
another question from the Jaspal Singh, Amritsar, Punjab.
Yes.
What to do if there is avian of radial head even after the reduction?
Yes. So
How to deal with the avian even though you are reduced well, but still it has gone into the avian?
so Kapil, would you like to answer that question?
Yeah, I think a radial head avian, one will have to follow a wait and watch kind of a policy, because these kind of evolve over a period of time, and something which looks really bad initially may kind of shape into not so bad later on. In
Yeah.
any case, in a young child, we have already discussed that you don't want to take any radical step like excising the radial head.
Right.
So, to the best of my knowledge, there are no kind of modalities with which you can revascularize the radial head in an acute setting.
Right.
Okay.
Kamlesh, you want to say something, Kamlesh?
Yeah, see in AVN, most of whenever the child is young, there are revascularization is high. If even there is asymptomatic child, the most of AVN of radial child, like with open reduction, and I have some cases like open reduction that leads AVN, but there are no complaint at all. So there are no complaint, and we should not address it. It will generally younger age, it will remodel, it will revascularize.
So the key thing is many a times the X-rays are looking worse than clinical picture, and clinically AVN they heal with a hypertrophied radial heads, and they have some terminal rotational restriction and no other problem. So we don't do an aggressive surgical treatment there. Yes, Navin bhai,
Now,
next question.
now question is fully rotated head treatment plan. Fully
Yes.
rotated.
So Dhiren bhai, you want to say something? Fully rotated, not in contact. Now there is a paper, very interesting paper, that when the radial head has some contact with the distal fragment, the outcomes are better. And when the radial head is completely away from the shaft, that means that there is ligamentous injury and there is some vascular problem also. The results are not great. But key thing is in those patients we would like we have to do open reduction. Dhiren bhai, what do you suggest for this completely tripled off and separated radial head? Dhiren bhai.
Yeah, what you said is absolutely right, that when there is a full displacement or 100% displacement, there is a loss of blood supply. So avascular necrosis is going to be one major issue, even like even if you reduce it well. Uh, the procedure or the protocol is same. We try with the non-invasive method. Not possible, we go for a joystick, and if it does not work, in that case we go for the open reduction. But
Exactly.
the reduction should be achieved to the acceptable range, that is less than 30 degree, by whatever mean it is possible.
Okay.
Yes.
Dr. Dinesh Sharma from the Haryana. Any role of arthrography to check the reduction? Do you do the arthrography?
Yeah.
Yes.
The
So
injection and checking the
we
reduction.
will
Yeah.
discuss, Navin bhai, we have that point in subsequent Montegia thing, and
Okay.
we'll
Okay. Then now the question is for old isolated radial head dislocation, what is the treatment?
so
And
that will
somebody has
come.
also asked about the comminuted radial head, which is rare, I think.
Yeah, so comminuted radial head is very rare in pediatric age group, and we are going to discuss this Montegia dislocation
No,
in a
no. What
moment.
about the radial head dislocation, old isolated?
So when we talk about this
Isolated radial
isolated
head
radial
dislocation is
head,
very rare.
Correct.
yeah, so there can be a congenital dislocation, and the results of congenital dislocation reconstructions are not very promising. And the one which we are associated with an ulnar fracture, kind of missed Montegia, that we'll discuss in subsequent session.
Okay, no issue. Now you go ahead. Then again
Perfect.
we will take the questions.
Perfect. So now let's embark on acute Montegia fracture dislocation. So let's see this first case. A 3-year-old girl with forearm pain presented mainly on the mid shaft ulna, and these are the X-rays taken by our orthopedic colleague. Now my question to Gaurav and then to Kamlesh and then finally Dr. Ved Mida, that are you happy with this imaging? Yes, Gaurav.
Yeah, so I think we should include both the joints, the wrist and the elbow, to rule out Montegia in any case of a ulnar fracture. So in this case, I can see that the lateral view does not include the elbow joint.
Right.
Also, yeah. Also,
Yes.
what I
So
feel is we should get the X-ray of the opposite side also.
right. So whenever you are in doubt, as we can see here, the radial head is probably cartilaginous and we are not able to see. So your suggestion is one joint above and one joint below. Yes,
And
Kamlesh, what do you think? What would you like to add something to this?
Yeah, same, because patient having a forearm pain, so at least and there is a trauma. I think history of trauma will be there. So at least elbow should be there. Elbow lateral view is not there. And another view, see in the lateral view, you can see that there is a ulnar bowing is also there. So better say we our mind we have to keep in mind for Montegia. So
Right.
lateral view is necessary. Yeah.
Exactly.
Nolin,
Yes,
yeah, not only
Doctor.
not
Yes,
not
Rudra.
not
just
only
a
both.
point to say about the clinical examination for youngsters. One of the presentation in children for a Montegia dislocation is forearm pain and the wrist pain. Many a time,
Right.
rich kids come with the history of wrist pain,
Right.
and you try to examine the distal radius, thinking that there is a fracture, and if you don't do an X-ray at the elbow, you can totally miss it.
Right.
So
And
So agree with you, Dr.
and
Meeda.
and
What is your comment on this imaging?
not only both the joints should be there, it should be a proper lateral view. This is an oblique view of the forearm. So yes, especially if you are taking the elbow, it should be
Yeah.
in the proper lateral plane rather than.
Right. So that's a problem sometimes in children that they do not allow because they are painful. But this is a rule that whenever we see a forearm injury, especially an ulnar fracture or even plastic deformation, we should include a joint above and joint below because there is high likelihood of having a Monteggia fracture. And many times our general orthopedic colleagues, when see this X-ray and as the radial head is not ossified, again they are not sure what's going on. Mandar, would you like to comment on this lateral X-ray? What is going on? You are mute, Mandar. You are mute.
Yeah. So in this case, you can see I always draw these two lines, which is the Mubarak's line and the radiocapitular line. And in
Right.
both the cases, this is abnormal. You can see that there is a slight ulnar bowing, which has pushed the radial head anteriorly. So if you draw a line through the radial shaft or the radial neck, you can see that the radial it is passing anterior or superior to the capitulum, and that
Right.
shows that the radial head is dislocated. So this seems to be a type 1 Monteggia equivalent. So radial
Right. So
plastic
this is
deformation of the
a
ulna with radial head dislocation.
agree. So, and Kamlesh, how frequently you use this Mubarak's line in your practice? Are you worried when you see this Mubarak line? Do you know what is the measurement or how we should use that line?
Yeah, definitely. Yeah, we all lateral we will draw a Mubarak line. So
Okay.
how we will draw it? So from the dorsal view, exact lateral, it's a end of we make a straight line from the olecranon to the metaphysis of distal ulna. So if you draw a line, there will be no convexity. If you see the concavity, so the vertical measurements from the dorsal border of cortex to the line. So if it is the more than one reference point, it's suggesting there is ulnar bow. The ulnar bow
Right.
is, yeah, it suggests there might be a plastic deformation of ulna.
So the key thing is the radiocapitular joint line is very consistent in all the range of flexion and extension. So radiocapitular alignment is very much important. Whenever you are in doubt or radial head is not ossified, do not hesitate to X-ray the other side, and that will give you clue what is happening. So Monteggia, if you will be surprised, delegates, that Monteggia is the most missed diagnosis in children's fractures. And the key question is how to avoid missing Monteggia fracture dislocation. I would like to re-emphasize this. Atul, what would you like to advise to delegates that how we can avoid missing Monteggia? Because we see lots and lots of missed Monteggia fractures. Atul.
One of the key thing is to understand that if you see a fracture of the ulna, you think it's a Monteggia fracture unless proved otherwise. And we've done this study of about 28 children and who misses the Monteggia. So we found children who have green stick fractures, children more than 7 years of age. 50% of them had poor quality X-rays, and it was equally missed by consultants as well as by people in residence and training. So if you go with the premise that every ulna fracture is a Monteggia, unless proven otherwise, that's the only way you can defeat the entity.
Right.
Because otherwise, like Rudra said, you must assess the child clinically. You know, if the child says pain in the wrist, always take an X-ray of the elbow.
So it's like in current scenario, the patient comes to your clinic, you have to understand they are COVID positive and you treat them, right?
You assume that way,
So we should consider all the ulnar fractures as they have Monteggia. So try and image them. Dhiren bhai, what will be your advice to all the colleagues?
Right. The first point you have very well shown that if you take a short X-ray which is not covering both the joint, there is a high possibility that we will miss the Monteggia injury. So that's the first thing I would suggest, like have a proper X-ray. The second thing, very good proverb says like eyes don't see what mind doesn't know. So the same thing, what the two line, the Mubarak line and the radiocapitular line, if we don't know, then probably we will miss that injury also. The third thing is like we will come to the treatment and the type 1 type of injury. Usually if you are not taking regular X-ray or if you are not treating it well, there are chances that you will end up with after 6 weeks or so with an injury. So these are the reasons of missed Montegia type of injury.
So the key thing, yes, Atul, what you want to add into
The
this?
thing I want to add is you don't use the Bedo classification. You use the word ABCD. So
Yeah.
ABCD stands for angulation, broken
So
bone.
we are coming to that, Atul, and I'll take your take on that. Yes, Mandar, what you want to add?
Yeah, the one thing which Atul sir said about who missed the Monteja dislocation, the most common person who misses is the radiologist. So one person is that we have to always explain to the radiologist. Many a times the patient comes with an X-ray report where they have probably at the most seen a board ulna, but many a times they have missed the radial head dislocation. So I think one main thing is that the radiology colleagues also have to be educated about this entity of a plastic deformation of ulna with the radial head dislocation.
Right. So the classification of this montage, as Atul mentioned just a minute before, that we should not use just the Bedo classification, but let me, for the delegates' interest, and when we are talking to someone, we want to have a common language. The Bedo classification has been described in 1967 with 4 distinct types. That type 1 is an anterior dislocation of radial head. 2 is a posterior dislocation, which is little rare. Type 3 is a lateral dislocation, and type 4 is both the radius and ulna fractures and dislocation. So there is something very typical about type 3 Bedo injury, and I like Anirban to comment on that. Anirban, when you see a type 3 Bedo, what will come to your mind?
Well, it is a highly unstable situation. And again, because it is a type 3, I would be associated to look for any nerve injury.
Right. So it's about 80% instances with type 3 injury, there is an posterior interosseous nerve palsy. So if your resident is showing you this X-ray, ask whether this child is having nerve injury or not. Now, as Atul mentioned that this Bedo classification suggests dislocation with all ulna fractures, let's describe one more classification, and he mentioned 2 more types, that radial head can dislocate without even ulna fracture. That we all must understand. The case which I shown is a plastic deformation or anterior bend can also lead to radial head dislocation and anterior green stick fracture. These 2 types were added later on to this existing Bedo classification. Now let's see some cases, and I would like to have opinion from my faculties that this is a 3-year-old girl, and she sustained this injury. How would you treat this? Kapil, what is your take? How would you treat this patients typically?
So, assuming, Molan, that this is a fresh fracture or it's a fresh
Yes, it is. This is
injury.
acute Montegia, yeah.
Yeah, so this is a plastic deformation of the ulnar shaft with a
Right.
radial head dislocation. And I think the plastic deformations are not easy to correct. You need a sustained kind of a pressure over a bolster for several minutes to correct the plastic deformation. And then once the radial deformation kind of corrects, the radial head should fall back. Otherwise, you can use manual pressure from the anterior side and supinate the forearm to kind of neutralize the effect of the biceps, and then flex the elbow more than 90 degrees again to reduce the deformation effect of the biceps. So these are maneuvers probably that should reduce the dislocation and straighten the ulna.
In acute settings, yeah. So
Correct.
Anirban, what do you do? How do you? Your goal is to only reduce radial neck, or you also try to correct the plastic deformation in this patient?
I would attempt to correct the plastic deformation, because that is the key. I mean, we know from our knowledge of chronic contagions also that the ulnar osteotomy is a key component of trying to get the radial head to reduce. So unless you reduce, or at least the degree of angulation of the plastic bowing is reduced, the radial head is unlikely to reduce by itself. And even if it does reduce, it may not be stable throughout the entire flexion extension arc. And that is what we are aiming at. We need the radiocapitular joint to be aligned and remain stable throughout the range of motion of flexion extension. So again, I would first try and correct the plastic deformation. Oftentimes, by correcting the plastic deformation itself, you would find that the radial head sits down into its anatomical
Right.
position. After that, I would check the position, arrange the entire elbow and see the stability. If it is stable, then I would just cast and do a weekly follow-up. If it is not reducing, or even after correcting the ulnar, then I would not hesitate to proceed with an ulnar osteotomy.
Okay.
I think,
So
Maulin,
like,
what needs to be stressed is reduction is one thing, but it's important to maintain it
maintain.
with a well
Stability.
confirmed cast
Yeah.
Right.
with a 3 point fixation, because as the
Right.
swelling comes down, it might, slip again.
Re-subluxate. Yeah. So I'll just take you through what was done. Like we flexed the elbow and it still remained sublux, as you can see. Now we must understand that this is not a reduced radial head. You have to draw a line from the center of radial head, and this is not crossing the capitulum. But the moment I pushed on these ulna as well as the front of the radius, it gave a pop and it came into this position. So now we are sure that this is well reduced, and then I checked in full range of extension and flexion, and it remained located in all the angles. The trans radial line was going through the capitulum, and we applied plaster in about 90-degree flexion, and then this child did well thereafter. So the question to colleagues is how long to immobilize once this, or how to do follow up. What is the frequency and when you take X-ray? Yes, Bobby. How will
Yeah. Can I add one more thing? I think it's important that you give the plaster in supination,
right?
Yeah.
because that is what holds the head reduced by
Yeah,
tightening
so
up the
in
interosseous
radial
gap.
neck fracture, we tend to apply in pronation, but when Montagia fractures, we try to apply it in supination because that's the key position which maintains the agree with you, Bobby.
And
So
since
now how,
and since we'd not done any intervention other than the plaster, I would have a very low threshold to repeat an X-ray, maybe at the
Yeah.
end of 48 hours,
okay,
and go back again, within a week, because I still have the opportunity to reduce it if I had to.
right. So yes, Mandar, how frequently you will follow this patient and will take X-ray?
Yeah, I'll definitely take X-rays every week. At least a lateral view X-ray, especially if it's a type 1 Vado injury. I'll take X-rays every week. Keep the plaster on for at least about 3 to 4 weeks, and then start with graded mobilization.
Right.
Because we
And
know that chronic dislocations can occur over time as the plaster gets loose. So I would like to see him every week with an X-ray.
so you will immobilize for 4 weeks, right?
Yeah, about 3 to 4 weeks.
Yes, Rudra, what precautions and what are the possible complications with this technique?
Yeah,
Rudra.
I think as discussed, it's very important to do a good follow-up of these patients. And as any of these very trivial, tricky situations in pediatric practice, weekly once we call them and do an X-ray. And possible complication is there is the redislocation of the radial head is always a possibility. That one has to keep it in mind. And if it is noticed within 3 weeks, probably it's easy to probably revise it and take the child to anesthesia and then do the same whatever you did it in more and then do a good cast index plaster cast. So that's what we have to do. But more than 3 weeks, probably then we'll have to consider doing an osteotomy and things like that.
Right. One more thing is many times we end up giving cast in a little bit more flexion than 90 degrees. So a compartment syndrome is always a problem. So we have to be very artistic in applying this cast and to avoid any compression across the elbow. So that's one more thing. Now let's come to this second case. This is a 2-year-old girl. She fell from a vehicle and this is the injury. So I'll ask this question to Kamlesh, Atul, Dhiren, and then Dr. Thakkar. Let's take opinion of Dr. Thakkar. How would you manage this child? Whether you will just do a close reduction or you would do you add something to your close reduction.
Yeah, definitely. This is a displaced uh, Montagia fracture dislocation. It, initially, it needs close reduction, and it has to be managed in a close way.
Yeah. So you suggested to do a close reduction. Kamlesh, what is your opinion? This is a short oblique fracture of ulna.
Yeah.
And would just a close reduction suffice, or you want to add something?
See, the two things I noticed. See, it is not mostly, it's a type 1 or 3. I think it's a radiocapitular line. It is also translated. So there is a lateral translation, and apex is toward lateral side. And the fracture pattern is it's a oblique pattern. So I will go for a close reduction. But the management principle, that's a three main principle. First of all, the correction of the ulnar deformity. Another thing, the correction of capitular radial dislocation. And third thing, to maintain the ulnar length. That is very important, because sometimes that shortening will give redisplacement. So I will close reduction, but because of the pattern of ulnar fracture, I will fix by close method or whatever, like intramedullary nail. So I will go for a close reduction, fixation of ulna, and close reduction for radiocapitular dislocations.
Yes, Atul, now you can see that the radial head is not visible. Would you do anything more than that to visualize the radial head here, Atul?
No, I know this is a Monteja fracture, and like what Kamlesh said, you look at the angulation, it is lateral angulation. There is a length unstable fracture of the ulna.
Right.
And you know that there is going to be a head here. The other way you can confirm is by doing an arthrogram. So
exactly.
So I would fix this fracture certainly with a rod or with a plate, because it's length unstable.
Right.
And it will fall back in place. And again, with this type 3, you have to be careful that it crosses nerves.
Right.
The pain involvement or no. And one can do arthrogram to confirm that the cartilage part of the head is well located, especially in 3.
Yes, Dr. Dhiren Bhai, we would like to add to this approach of Atul, or you
just
will
agree with that. It's a type 3 injury, and we have to go for the operative intervention for ulna. If it's actually unstable, then plate actually stable, then nail will be suffice. But we have to restore the angle as well as the length of ulna, which is a key point for this.
So the key point is to maintain this is short oblique, and just by applying cast, there is some chance that it may get redisplaced and the radial head may get out of its position. So these are the questions we already answer. And this is just a small technique of elbow arthrogram with posterior portal. We use Omnipack die, take 2 ml die and 3 ml saline. And I pass the nail from the lateral side of olecranon. This is the medial side and this is the lateral side. You feel that triangular space between the radial head and the olecranon, and just put your needle there, and then you inject. There should be free flow of dye, and then this is the way you can very easily do an arthrogram. The one more portal which has been described is a lateral portal, and this, you see, there's a very easy flow of dye. If there is resistance, then you just make sure that you are in the joint, and you can visualize the outline of radial head like this. So that's what we did, intramedullary nailing and an arthrogram to visualize the end of radial head, and it was well reduced. This is a 3-month follow-up, and this is clinical follow-up. So the lesson was, with a short oblique fracture, maintaining the length is of great importance. Now, this is a nice case from Dr. Kapil Gangwal, and this case is a 10 years old boy who presented with this kind of X-ray picture. And I like to know from Dr. Ved Mida first. So how would you like to treat this patient? This is a 10-year-old boy with a closed injury. Dr. Mida, are you with us?
Yeah. Yes.
Yeah.
It's an intra-articular fracture of the upper end of ulna, along with the dislocation of the head, along with the ulna. So there is not dislocation of the radial head. Actually, the head has dislocated with the radial fossa of the ulna itself. So it's more of a upper ulna fracture rather than a Monteja fracture. We'll treat as a intra-articular upper ulna fracture and treat it accordingly by reducing it anatomically and fixing it with a screw, or if needed, a plate.
Right.
Radial head will fall in its place. I think radial head is not
so
dislocated.
here ulna fixation is a key thing. Yeah, I agree with you.
Yeah.
Yes, Gaurav, what do you think? How would you go ahead and fix this situation?
Yeah, so I agree with Dr. Medha that we have to manage the ulna fracture, and it's a long oblique fracture in the olecranon. So I would also like to plate it and see the.
Would you just reduce it and put a nail across, a thick nail across?
No.
I think the proximal fragment is very small, so I would like to put put a plate with a few screws there to have a
Right.
more stable fixation.
So putting only intramedullary nail will not give you a good stability or rotational stability. That's the key. Now, Kapil has inherited this case. Kapil, would you like to tell the story to the delegates, Kapil?
I always
Yeah.
teach. Sorry, I always
Yes,
teach
yes, please, Dr.
I always teach intra-articular fractures means anatomical reduction is important, and
Right.
absolute fixation is the key.
Right. Agree with you, sir.
Rigid
Absolutely. Yes,
fixation.
Kapil.
Yeah, so Molin, this is kind of a Monteggia variant in which there's a proximal ulna olecranon fracture with the radial head dislocation. And when this child was taken in the operating room and the fracture was open to reduce it, it fell into place nicely. And as the ulnar fracture was reduced, the radial head also fell into place. And it was opted at that time to fix it with a tension band wire construct, and it looked quite stable intraoperatively. But post-operatively, when we took the X-ray, and if you'll advance the slide, this is what the position was. And that's really something which makes you fall on your face when you look at that X-ray post-operatively, because it was hard to imagine that why the fracture displaced when it was so stable intraoperatively. And I think retrospectively, now looking at it, I think the fixation was unstable. And often when the effect of the anesthesia wears off and the biceps becomes active, it sometimes pulls the radial head back out of the reduced position. So we had to go in and redo this fracture. And like everybody said, we had to put some interfragmentary screws and plate it. And this was then stable and went on to heal nicely.
Yeah, so Kapil has sent me a nice clinical picture, and this child had ended up in a great range of motion.
Can I
Yes,
add here?
Dr. Mida, yes, please.
Actually, it will be wrong to designate this as a Monteggia fracture because the radial head is still in normal relation with the ulna.
Yeah.
So it's to be treated as a upper ulnar fracture rather than as a Monteggia.
Yeah, so this is one of the variant of Monteggia. And so the key message here is not all the fractures in children are amenable to the basic or smaller treatment or simpler treatment. You have to apply the principle, and there are papers. Now, this is a nice paper from Peter Waters and David Ring, and they have set an algorithm for management of acute Monteggia fracture. Now, what they found 4 patterns where plastic deformation and Grinstick fractures are the first 2 patterns where you can do closed reduction and casting only. When it comes to transverse or short oblique complete fracture, you do closed reduction and intramedullary nailing. But when it comes to long oblique or comminuted fracture, or in other words, length unstable fracture, you do open reduction and plate fixation. So this was the algorithm they devised in 1996. And then they retrospectively studied as a multi-center examination of treatment strategy. And they found the data of 112 patients. In 32 patients where the protocol was less aggressively followed, meaning that for length unstable fracture where ulnar nailing was done, or a short oblique fracture when conservative or just casting was done, in about 33% of time, the treatment failed in terms of radial head redislocation or loss of ulnar reduction. So this shows that if we do not follow this algorithm, one third time we may fail in treatment. So this is a very nice paper, and this algorithm gives a clue about how to manage acute Monteggia fracture dislocation. So now with that, we will come to the last part of our talk, missed Monteggia fracture dislocation. And Navin bhai, I'll be happy to take some questions here.
Okay, the questions are there. Let me put the questions, and I will require to share the screen also for one pediatric orthopedic society member has sent the x-rays.
Yes.
Let me check whether it works here or not.
Maulin, I have sent you X-ray on WhatsApp.
Okay.
Please check.
So
can you send it to Navin bhai? Because
Navin, I will be able to show you. This is Dr. Praveen. Dr. Praveen, the full name I forgot. Dr. Praveen is a POSI member. He's a POSI member. Praveen Kabra.
Okay.
Praveen Kabra. Yeah, Praveen Kabra. This is the X-ray he has said, and this is the case about he received just where 8 years male child with recurrent dislocation of elbow with treatment taken at the local level.
Yeah.
This is 8 year
So
old
we are like I'm not able to see the X-rays very. It's a posterior dislocation.
Yeah, you can see now. I can
Yeah.
zoom it.
Okay. Yeah. So
It's a poor quality X-ray. I mentioned
yeah.
him that if you have got a good quality, okay, but it will do.
So this is a recurrent anterior dislocation, and
Yeah.
Anirban, you would like to take this case. How would you manage this situation? This is a very rare situation, and I have not come across very frequently. But Anirban, your experience?
Maulin, is
Recurrent
it
dislocation.
Yes, Dhiren bhai.
Maulin, is it anterior dislocation or a posterior dislocation?
I think
Looks like a posterior.
posterior
It's
dislocation
a
with
posterior.
the
It's a
yeah.
posterior one. It's a
And
posterior.
probably
Posterior.
the coronoid part does not appear to be normal. So probably something is wrong at that
Wrong with the
area.
coronoid. Yeah.
It requires a CT or MRI. I think he has not done the
Exactly.
CT and MRI. CT and
So
MRI is required.
Yeah. Let's yeah. So
If it is a recurrently dislocating elbow, that means we have to think that it is a global injury to the ligaments. It is not just an isolated injury. So again, like we spoke earlier, this could be a variant of a terrible triad, and that is where the ligamentous repair becomes more important, and to get your stability rather than just the bony fracture.
Maulin, can I come
yes,
in?
yes, Mandar, please.
Yeah, if you go to the X-ray, the radial head is lying towards the medial epicondyle, which means that it is a translocation. So this is a posterior dislocation with a translocation of the elbow.
Yeah, that
is not a very good.
You can
quality.
see that the radial head is on the
so
side.
that's a possibility. Agree. Now,
and especially if you can see the pronation, the X-ray in pronation. So it's a locked,
Maulin,
pronated, convergent
Maulin,
translocation.
anything can be possible in this case. Anything can be possible in this case. It may be avulsion of the medial epicondyle to the radial head fracture. Some kind of interposition may be there.
so let me conclude this that if it is a recurrent dislocation with a coronoid dysplasia, as Anirban suggested, it needs ligamentous reconstruction. If it is a translocation of radial head, which is a very rare entity, as Mandar said, it will need an open reduction, and in both the situations, results are sometimes promising. So can we go to the next question with the good images?
There is no good images. This was the only image. And the next question is any experience of using, Dr. Tejas Gandhi has asked, any experience of using in such case of ligament injury with the anchors?
Yes,
Anchor,
Rudra, any experience?
Anchor fixation.
So that is in case of an adult, but generally in pediatric, as Mandar was describing, the ligamental injury per se are not so common.
Yeah.
It may be if it is a child with more than 12-year, 13-year-old, probably yes, we can use the shoulder anchors, which are available, and I have done few cases, especially the lateral collateral ligaments. We can use shoulder anchors, 6.5 or 5.5 mm anchors to use the ligament.
This is Anirban's X-ray. He has said it.
Yes, Anirban, tell the story.
This is again something which I inherited. A patient had come for a second opinion. This is exactly what we were discussing, that a transcapitular wire may be inserted, giving a false sense of security that it has been reduced, but it shows that the wire, the reduction is not there. So,
and again, the ulnar plate, ulnar shape is like concave. It's not corrected ulnar part.
Yes.
So the ulnar osteotomy or the fracture was probably fixed, but the bowing was not corrected. And, an attempt was made to try and reduce it. So these are the cases where the wire is invariably either going to break or migrate or something. It is not going to be retained.
So the purpose,
right?
yeah.
Yeah. So
yes, Navin bhai, further question?
The further, Dr. Praveen Kabra is writing that is there a possibility of a cross union or an open reduction followed by X fix with the hinge joints? With this elbow dislocation case, he is writing. Is there a possibility of removal of heterogenic ossification? There is ossification of a cross union that he is talking about synostosis proximal.
So
I think.
we must get a CT scan and a good quality X-ray to see. Sometimes they have synostosis and anterior dislocation. Sometimes it may be an osteochondroma arising from the proximal radioulnar joint. So a great imaging can be
Yeah, yeah.
given to
The
me.
same.
I'll forward to, and
Yeah,
then
yeah,
we'll
yeah,
answer this.
yeah, yeah. Now the question: in plastic deformation of the ulna, not able to correct, what should be done to reduce the radial head? This is the question asked by Dr. Wankhede.
Yes, Kapil, would you like to answer?
Yeah, so I think what's important to understand is that the radial head
Can you be a little
dislocation.
louder, Kapil?
Yeah, so
Because you are not using that earbuds, so
no,
just
I do
come.
have them. Yeah.
Okay, then
So
volume, increase your volume.
okay. So I think the plastic deformation sometimes is hard to correct because that ulna has a spring and it may kind of fall back again. But the radial head can reduce if you supinate the forearm, and you can use manual pressure from the anterior side of the elbow to push it in place. And then if you flex the elbow more than 90 degrees, then that should kind of take away the effect of the biceps, because actually it's the biceps which is pulling the radial head off from the joint. So I think these three maneuvers are there which should reduce the radial head. And if it still is not reducible with these maneuvers, then there's probably something which is impinging, and you may want to do arthrogram or more imaging, and if not, then try and do an open reduction.
Yes, I'd like to share three experience. One is there are instances where the radial head pops in, it is stable in the range, and plastic deformation could not be corrected intraoperatively completely. But once the radial head remains in, and gradually over a few years, we see that plastic deformation gets remodeled. So that can be a situation. The second thing, I came across a recent experience where the radial head, even though it's an acute injury, I could not reduce by close means, and there was not much ulnar deformity. And when I had to open it, and I saw that there was buttonholing of radial head through the annular ligament, and had to make some radial cuts. So that can happen in acute situation, that you may not be able to reduce radial head, but that's a very rare situation. And finally, I have seen that for 4 weeks, the radial head is sitting in. And when parents try to do overzealous extension or elbow extension exercise, the biceps can pull back the radial head out. So we have to advise the family that the post plaster removal rehabilitation should be gradual. If they jerk it, then biceps can pull that radial head outside again. So that's one thing which should be kept in mind. Yes, Navin bhai.
Now the question is, uh, in a conservative management, this is second time asked because previously it was not answered, and I think it is already answered in your lecture, but still is asking, in conservative treatment of Monteja 3, how much is the elbow flex and whether the arm should be in the mid prone or fully supinated in context to ulnar bowing during cast?
So yes, I'll ask Kamlesh. Would you like to answer that question? What should be the position when you are dealing with a close treatment of Bedo type 3 or lateral fracture dislocation
Yes.
with plastic deformation? Kamlesh.
Yeah, the same things. We will reduce in the same supination maneuver. Once it is reduced, it's supination. So give a slab more. See, I prefer it's not a 90-degree, little bit 100-degree flexion. So supination and 100-degree flexion, that will prevent further progression of dislocations.
Okay.
The problem with the Bedo type 3 is it is difficult. It's a coronal deformity. So taking an AP X-ray with the elbow flexed at 90 degrees is sometimes difficult. So that's a problem with the Bedo type 3. So as Kamlesh said, that once you reduce it, try to apply plaster in about 100-degree and take an X-ray in AP plane and remember that plane. So you have to not to compare with the pre-treatment, but you have to compare the immediate post-reduction film, and that alignment should be maintained, because you will not be able to see exactly the radiocapital alignment because of the elbow flexion. There will be some overlap.
Okay. Dr. Mehpatsi Parmar is again asked, while nailing the ulna, entry through the epiphysis or should we go to distal to the epiphysis? Nailing.
The dictum I follow is, whenever in doubt, put an intramedullary wire. You will always be safer.
Yeah. Yes. So entry of ulna nail, Dhiren bhai. what is your practice?
Yes.
Through the physis, through the tip, or from the side, what do you do?
Yeah, usually like in this case, we have to keep it only for like 6 weeks or so, because by that time the fracture will unite, and the length will be maintained. So our main aim is to maintain the length. So I keep it outside the skin and through the physis.
Through the physis. Yes,
Physis straight.
Bobby, your comment, anything different? Yeah, you are mute. You are mute, Bobby. You are mute.
You're mute, please.
My view would be a little different here. Yeah, it's one thing to get the head reduced, but it's also important to ensure that your plastic deformation is corrected. I would rather maybe make a few percutaneous holes at the level of the bend to straighten it and then give it into a cast. I wouldn't really depend on a wire itself just to hold the reduction in place.
Yeah. So the question was to entry point of nail. Anything other? I take lateral entry for the passing intramedullary nail. Don't go through the physis. Not because of fear of physial injury, but because of fear of a tip of nail can irritate the underlying skin. And rarely we know that ulnar nerve is quite kilometers away. But when your fellow is doing, it's very wise to teach them to go from the lateral side, little distal to the physis, and that also works. Yes, Dhiren bhai, your comment.
Yeah, Mavlin, what you said is absolutely right. Like if we are doing for the fracture radius ulna intramedullary nailing, and where we want to keep it for a longer period, the entry which you suggested is very important, because in that case, when child keeps the elbow on the like the table, or on this way, if it's a lateral entry, it would not hurt the child. But here anyway, we are keeping it for only a short period, so the entry does not make much difference.
Yes, so my firstly, this is the answer, very clear.
Yeah,
yes.
okay. The next by Dr. Tejas Gandhi again.
Yes.
He has extended the question. Can we use the hook plate for the proximal ulna in a child when the fracture is proximal? Concern regarding the epiphyseal injury again. Hook plate can be used or not?
Anirban, you want to answer that question? What is the effect of your wire or screw going through physis in children?
Hook plate.
Or a hook plate, in other words. Yes, you are mute. Anirban, can you bring your mic on? Yes.
Yeah, you actually don't need such a aggressive implant inside. A simple wire is enough to maintain. The aim is to maintain the length of the ulna and to maintain the bowing. And a simple K wire can solve that issue. So I don't think there is a need of putting too much of exposure and putting a big plate, and it's not really required.
So Navin bhai, we did not discuss one case which is described by Newman in 1970s, which is a lateral shear injury, where the radial neck and proximal ulna both gets fractured. There was a wonderful case shared by Mandar, but due to sake of time I could not. Mandar, can you tell the delegates how you would fix the proximal ulna fracture in children? We do not need to. Yes, Mandar, please share your technique.
So I think there was a discussion about the proximal ulnar physis or the olecranon physis. Now, what is important to remember that the olecranon physis is an apophysis. It's the traction apophysis of the triceps. So there's very little growth potential for that physis. So in case you need to stabilize a very proximal ulna, so it's like an olecranon where, so the case which I showed had a shear fracture of the olecranon with the radial neck fracture, in which case it was extremely important for me to have a very stable fixation. In which case you have to treat it, go through the physis, it doesn't matter, because there is very little actual growth potential to the proximal ulnar physis. So it's an apophysis, that is what we need to remember. And you should have achieved good reduction and fixation of that proximal ulnar fragment.
So that you did with a tension band wiring using ethibond, right? That's what I wanted to bring here.
So I've passed K wires through the fracture as is usually done, as well as TBW, which I used using a thick ethibond.
So in pediatric age group, we do not use that SS wires many times, but a suture material like ethibond can work as an tension band wire. Yes, Navin, by any further question?
Dr. Praveen Khabra has now shared the image of how he is treated with the previous case. Open reduction followed by X-fix with the hinge joint and removal of heterogenic ossification treatment given like this. he has sent this X-ray. Any comments?
So
He has tried to fix that recurrent elbow dislocation case. Kabra Hospital, Mahesh Nagar, Aurangabad.
yeah, so he let him also tell what he has done exactly. Is
But
it something a distal
he has
ulnar
not.
pin?
He has not written anything. He has sent this X-ray only.
I think
Too
we
much
should
flexion,
discuss
too
this
much
case after
flexion.
the webinar.
Okay,
Navin bhai, can you go with?
we'll discuss. Okay, no issue, no issue, no issue. I am
Yeah, let's
stopping the
talk.
More
sharing.
like
You
a
go ahead.
transolecranon pin.
Transolecron pin. Yeah,
Yeah,
yeah.
let's discuss other case, Navin bhai, please.
Okay. No issue. The questions now are remaining are uh, somebody has asked what the faculty will choose, a tens or a plate, nail or a plate in Montegia, please. What is the opinion of house? General, it's a generalized question.
So let me make it very clear. No need to answer. Dhiren bhai, what you say? So,
Yeah, see, like it's very clear-cut message you have already
yeah.
conveyed in the previous slide, the Peter Water paper.
Yeah, yes.
If it's a short oblique fracture or a transverse fracture, it's a length stable injury, we go for nail. If it's a comminuted fracture or a oblique fracture, which is, or a spiral fracture, which is length unstable, we need to go for a internal fixation, which is plate.
And for a plastic deformation, we just do casting. That's
yeah.
a period.
Okay. Now somebody, Dr. Sodi, has is saying that a plastic deformity of the ulna seen late, but having only cosmetic deformity on pronation, should we treat it or not?
No, they have a propensity to
Should prevent
gradually get remodeled over a period of time.
Okay. So there is a cross section of the learning curves are different. So you will get a variety type of the questions. So don't get disturbed.
No.
this is my daily experience.
Yeah, we understand that some
because
people have joined later.
You are so much experts that many times you this is like this only.
There is a cross section of joining the webinar time also, no?
Yeah.
Okay,
Absolutely
shall we
correct.
go ahead?
So these are all some small disadvantages of webinar. But if you do not answer, they get unnecessarily.
I know. These are wonderful questions, I must say.
Yeah.
You want me to share my screen now? Navin bhai?
Yeah. You can go ahead.
Okay. So let's come to the last part of our webinar, and that is missed Montegia fracture dislocation. And the first and foremost question which would come to general orthopedic colleagues' mind is how late is too late to reconstruct the missed Montegia? Or in other words, how much chronic Montegia we should try to reduce? And I'll ask this question to Atul, Mandar, and Rudra, and then finally to Dr. Mida, what he thinks about it. So Atul, how old is and too old to operate?
So I have done latest is 16 months. And,
okay.
In literature, reports have been as long as to 24 months. Beyond 24 months, generally the results are not very good.
Right.
Because of chance of stiffness and complications.
Yes.
So
yes, Mandar, your take on it?
Yeah, so I think literature is about 2 to 3 years is the highest age that we should reconstruct. I have done till about similar to what Atul sir said, about 18 to 20 months. However, what is very important to know is that what happens is in late dislocations is that the radial head starts becoming convex, and that is the time when it is not going to stay in even after you have done everything to the ulna and done everything to the radiocapitular joint. So probably a pre-op imaging is something which we need to look at the convexity of the radial head to decide whether it is worthwhile reconstructing a missed Montegia or not.
Right. And moreover, the convexity, the other thing is sometimes when the radius get entirely subluxed, there is more subperiosteal bone formation. So there is enlargement of the radial groove, neck, and which will not fit well into the radial notch of ulna. So yes, Rudra Prasad, what is your take? How old or how much old you will reduce?
I work for a tertiary care government hospital. Here we get children coming even after 2 years, 3 years also. And we have done, of course, attempting, reducing these dislocations neglected after 2.5 years, 3 years. But I must tell you, the results are very, very bad. I'm not so happy with, especially the neglected, which is coming after 1 year. even after 1 year, they're not so good. So there is no clear-cut duration as such, but it depends on the age of the child and the pathology involved also. But sometimes if there is a soft tissue interposition inside there, probably you're lucky and you can get along with clearance by open reduction. If there is some kind of a bone formation, as you were discussing, that adds to the complexity of the problem.
Right.
So in general, I think earlier the better. I would say that within 7 months to 8 months is what is good, results we can expect. At least year within a year, if they come, probably the results are good.
Yeah. So one more thing I would like to add, it also depends on the experience of surgeon. Like if you are an occasional Montegia surgeon, then please take help of a pediatric orthopedic colleagues, because I will share my experience that even after doing many cases, we may fumble inside the operation theater at many times.
Absolutely.
So with your wide experience, Dr. Ved Mida, what is your take on this? How old you have operated in Montegia?
I think late is a very relative term. Means you are
Yes.
challenging the nature's remodeling capacities to your surgical skills. Means yes, if the things are really remodeled or the radial head is too convex, then yes, reducing it back is not going to give you good results. But yes, I think up to 6 months is something which I'll be happy to do. But after that, I will put my reservations on the results the patient is expecting.
So this is what I have learned from Donald Bay from Boston Children's, that after 2 years they tend to get a 3D printing of the radius ulna and see whether that radius fits well into the radial notch of ulna. So they do 3D printing of that Montegia, and if it is fitting well, then only they try to put it back. Sometimes the geometrically also they are very bigger head and it will not fit. If we try to fit them, they will end up into stiffness. So this is a nice paper from Japan in JBJS 2009, and they found when the children were more than 3 years old injury, they have huge level of complication, and 7 out of those 10 had residual radial head deformity leading to restricted motion of forearm, and 6 out of 7 had radial head resubluxation and arthritic changes. So their cutoff, this Japanese paper is, if it is more than 3-year-old, then the results are poor most of the times. One more paper published in Journal of Children's Orthopedics in 2011, they say that when injury is more than 40 months, the rate of complications were very high. So by and large, 2.5, 3 years is a cutoff mark, after which attempting to reduce those radial heads are inviting problems. Now, when as a young pediatric orthopedic surgeon, when I saw this Montegia fracture dislocation, I tried to separate the elements of Montegia fracture dislocation, missed Montegia, and therein by what are the key elements of missed Montegia dislocation? How would you segregate them?
Okay, like this X-ray clearly shows that there is a ulna deformity. Because of the angulation, the ulna has become short because
Right.
it has lost its length. So the first is angulation, second is the length. The third thing which is apparent is there is a radiocapitular dislocation. If you draw a line along the long axis of radius, it's not passing through the capitulum. So that's the third component. The fourth component, which is not really appreciated by most of us, is that there is a proximal radioulnar joint subluxation or a dislocation. Because we are looking at the lateral view and we are not training our mind to think axially. So there is a proximal radioulnar joint dislocation also. And the two things which we don't appreciate on X-ray or we don't see on X-ray is that the interosseous membrane is also lost or it's deformed, and the annular ligament, they are also not competent. So these are the full spectrum of deformity which we see on this X-ray. Something is visible, something we have to imagine.
So this is a very nice comment that there are these 3 key elements. And many times our colleagues try to address only one element and they think that the other elements will be taken care of. So the next question is, can a missed Montegia be reduced by doing only ulnar osteotomy? Yes, Kapil, what do you think about it? Can we just do an ulnar osteotomy and we expect the radial head to get reduced forever?
Well, Molan, just when you try and go and reduce these chronic dislocations, the first step in the surgery is to do the ulnar osteotomy, and then
Yes.
you try and get a close reduction of the radial head dislocation. And every once in a while, you may be lucky enough that the radial head pops into place and may be stable. I think looking back to my experience, maybe 2 cases I recall where I was able to reduce the radial head just after having done the ulnar osteotomy. But in none of those 2 cases, the reduction was stable. And eventually, I did end up going and opening the radiocapitular joint and removing the fibrosis there. So maybe in very fresh cases or
Right.
ones which are not old, you may be lucky enough to do it. Yeah.
Yes, Dhiren bhai, what do you think about this?
Just coming to my last comment, like by ulnar osteotomy, what we can correct is we can correct the angulation. So if we really want to take care of the whole spectrum of problem, we need to distract the ulna also, so that the length of the ulna is increased. So with ulnar osteotomy, we are taking care of the two things, the angulation and the length problem. However, what we discuss about the radiocapitular joint, which is remain dislocated for such a long period, probably we will not be able to achieve only by ulnar osteotomy. What Kapil said, I fully agree with that. And we need to open the radiocapitular joint also.
Right. So key thing is for very young case or just a few months old cases, by approaching ulna first, doing an distraction, flexion, osteotomy, many a times radial head pops up, pops into its place. But when you are dealing with the more older cases, the annular ligament from where the radial head has got buttonhole, it gets contracted, and you have to clear the fibrosis into radiocapitular joint. There are some examples. Now, this 4-year-old boy with 2 months old injury, and the surgeon thought that by just doing an ulnar flexion and distraction osteotomy, we'll be able to achieve this radial head back. And intraoperatively, they were quite happy. There is mild subluxation anteriorly on pronation, but on supination, it remains well rotated. And they did this quite a substantial angle of correction. As you can see, it is an overcorrection of the ulnar deformity with a small bone piece. That's a distraction, but still you can see that the radial head is still subluxed. So many times, unless you clear the radiocapitular joint completely, you will not have a stable reduction. That's one. And the vice versa is also true. Many colleagues are trying to just do the radiocapitular reduction, and they feel that it will last forever. But sometimes we see in follow-up that ulnar deformity is persistent and radial head tries to jump out on follow-up exercises. So we must have the complete treatment, and there's no shortcut to the success. Now, if we try and do the complete sequence, I would like to inquire what is the sequence of treating Montagia, whether you approach the radiocapitular joint first and clean it, and then you do ulnar osteotomy, or you approach ulnar osteotomy first. Yes, Kamlesh, what is your technique and what is your approach to this?
Yeah, see, we are initially I approach radiocapitular joint because we use an extensile approach, and by using the same approach, we are will do ulnar osteotomy. So first of all, I prefer that you already told because it's a neglected Montagia. So there are a lot of hypertrophied synovium, might be annular ligament entrapment. So I will reduce first radiocapitular, then depending upon, so I will
Or
shift to
you
ulnar
clear
osteotomy.
the radiocapitular joint.
Yeah,
That's what you mean. Yeah.
yeah.
And then you'll go on ulnar side. Yes,
Yeah.
Anirban, what is your take on this?
Yeah, well, if you look at the original Hirayama's paper, they used the Boyd approach. They first did the open reduction of the radiocapitular joint. They reduced it, but they found it to be unstable. Then they went on to do the osteotomy and get the final stability. They did the osteotomy at about 5 centimeters from the olecranon and did about 1 centimeter of distraction. However, if you see the paper by Exner, where he described the gradual distraction with an external fixator, and in almost all his cases, he reported that they could do a gradual distraction and the radial head just reduced spontaneously. So both these things are there in literature, but personally, I would first do the osteotomy, see if it close reduces. If it doesn't, then I would do the open reduction, and rarely, if required, do the annular ligament.
Annular ligament. Okay. So I'll ask Bobby John. Bobby, what is your take on this? How what is the sequence in your practice?
Exactly what Anirban said.
Okay.
You know, it is not unusual for the early missed Montigias actually to fall back in place with just an ulnar osteotomy. And having said that, you're actually approaching it from a common approach, the Boyd's approach. It's just a matter of extending it to enter the radiocapsular joint if you have to.
So my question to all these people who like to do an proximal ulnar osteotomy first. So do you do a temporary fixation, or you do a fixed fixation based on your pre-op X-ray? Because there is a possibility that once you do a flexion distraction osteotomy, still your radial head may remain out. So how?
Temporary.
What do you do,
Temporary.
Bobby?
I would normally put, I mean, I would use a plate. I would use the proximal and distal screws to hold the osteotomy distracted and angulated. Check under the II to see that the head has fallen into place, and then complete my fixation. Or go ahead and open the radiocapsular joint.
Yes, Anirban, any technique or tips for doing this?
Yeah, if you see the paper from Boston, Donald Bay's paper on strategies on Miss Montegia, what they have said is that they first did the open reduction, put a temporary transcapitular pin, then did the osteotomy, got it into a further position, then they removed the pin at the end of the surgery. So the pin can be a useful adjunct temporarily, but it should not be used permanently.
That is an excellent technique. I think we all are well equipped, well experienced in treating DDHs. And in DDH, we do the same. Like once we do open reduction, and then we do the osteotomy of femur, then we put a temporary transfixing wire. And whatever overlap is there, the similar way we can use this a temporary transcapitular wire and see what is the angulation and distraction happens at ulna, and you fix that ulna in that position. So that's a wonderful technique, and thanks Anirban for bringing that in sequence. So any Atul, do you have any other approach, or you follow the same approach?
I almost follow the same technique, but what I do is I put 2 KYs in the ulna, because you want to also maintain the rotational stability of the ulna as well.
Okay.
So I'll put 2 KYs and I will angulate my plate and put the whole of the plate in each of the wires, and then distract it with a lamina spreader.
Yeah.
And if the distraction is more than 10 millimeters, I'll put a bone graft.
Okay.
And that, then you may get away without a graft. So I think it's very important for a long-standing Montegia. If it's more than 10 millimeters, you must have a graft either from the iliac crest or a local graft and pack it there. Otherwise,
right.
So,
so if it is just an open wedge osteotomy, they don't graft it. But if it is distraction more than 10 millimeter, you take an iliac crest graft. That's
invariably, you need distraction at least 7 to 10 millimeters. That's what in my experience in children more than 9 months of age.
So what is your end point? How much you would distract? Is it based on X-ray, or is it based on your clinical exam, or what? How would you decide?
No, so you can. It's on table decision. So you put a temporary wire, as Dr. Nirvan said, and then you distract to about 7-8 millimeters. Put 2 screws, check the stability. If it's stable, then you don't need to do anything else. If it's not stable, you can further distract to about 10 millimeters. If it's not stable again, then I would go ahead and do a ligament reconstruction.
Okay.
You can't go more than 10 millimeters.
Right. So let us see things one by one. So this is for, of course, the delegates to understand. Doing an open reduction of radiocapitular joint is just not like opening the capsule, but there are a lot of things lying therein. So we prefer a posterolateral extensile, either Coker's or Boyd's approach, and you reach to the radiocapitular joint. I tend to do a decompression of radial nerve anteriorly between brachioradialis and brachialis interval, just to decompress, because sometimes while doing a reduction or pulling the radial head down, there is history of some neuropraxia, but that is not a common practice. But one should go between Anconius and ECR interval and clear the radiocapitular and radioulnar joints and see what is happening with the annular ligament. And there can be 3 possibilities. One is the radial head might have buttonholed through the annular ligament. or it's torn, but still you can suture it. That's reconstructible, and that is completely destroyed. Those radial heads where we see that radial head is buttonholed through annual ligament, one should put some radial cuts, and through that radial cut you can enlarge the annual ligament and bring the radial head down. If it is torn or you need to cut it to bring the radial head down, then you can suture it end to end. And if it is completely destroyed and unstable, then you might require to reconstruct the ligament, which Atul will tell us in details later. So now the question comes about ulnar osteotomy. So the question is where to perform this ulnar osteotomy, because this deformity is usually lying little distal. So whether the ulnar osteotomy at the cora or proximal third. Rudra, what is your approach? Where would you perform ulnar osteotomy?
So as we are looking here at the reduction of the radial head mainly, and the osteotomy should be in the proximal region. So it will not be at the distal area. And then of course, as Atul was discussing, it is the distraction which is important than the angulation. And so the osteotomy should be proximal. It should not be too much proximal as well. And with relative to the cora, it should be proximal to that area. That's my opinion.
Yes, Gaurav, would you agree with Rudra, or you would like to add something to it?
Yeah, I would agree with Dr. Rudra that the osteotomy should be at the proximal third.
So the key thing is when we do a proximal osteotomy, we are pulling the interosseous membrane and we are trying to pull the radial head more down. We have seen that when the osteotomies are performed more distally, its effect to bring the radial head down is little less, and sometimes we fail. So that's the key point, that we should perform the ulnar osteotomy more proximally than at the cora. Now, this point we discussed already, that what are the types of ulnar osteotomy? Is it just a flexion or flexion distraction? And Atul, in your practice, how much percentage times you require flexion distraction, and what is the percent just flexion?
I think it's not on the percentage, it's the duration. So if the child comes beyond 9 months or 10 months of missed dislocation, inevitably they will need a distraction.
Right.
If it's just a 6-week or 2-month-old missed dislocation, yeah, I think the flexion should.
Yeah. So as you say that this is just a flexion osteotomy, and this is flexion distraction osteotomy. So Kapil, what is your take on how do you decide intraoperatively that you will require a distraction or not?
So I'll try and reduce the radial head in its position and just see where the ulnar osteotomy goes. So if it's mainly just angulating, then I won't add too much distraction to it. But if it falls apart, then add the distraction element to it. So basically, once the radial head is reduced, the ulna will fall back into a position of deformation, and you just take that position.
Now, in a Hirayama's technique, a modified Hirayama technique, the Japanese paper, they mentioned that the distance between capitulum and radius should be about a few millimeters. Otherwise, it will be a very stiff joint. So, any one of you follow that thing, that you try to keep some distance between radius and capitulum to keep it to prevent stiffness. Anirban, any thought on this?
Yeah, I think that paper mentioned that if you, it's like if you stuff that joint too much, then it will get too tight. So, but sometimes intraoperatively, it is often difficult to measure that those few millimeters. So ultimately, I guess most of us end up eyeballing it.
Right.
One point which I wanted to mention is that after doing the ulnar osteotomy and you allow it to take its own position, depending on whether the Montegia was originally a type 1 Bedo or maybe a type 3, apart from just angulating it in one direction, you also have to look at the mediolateral direction in which
Translation.
has to translation. Yeah.
So the next question is what the faculty prefer. Is it an acute ulnar lengthening or gradual lengthening? So Anirban, you mentioned the Exner's paper, and that paper has only few case reports actually. There's not a big series.
Yeah.
So would you like to do an gradual ulnar lengthening, or you are a fan of acute and plating? So this is the paper you were talking about.
Yeah. I actually do the something like this. But I do it acutely on table. I use a just distractor and gradually distract it so that I know till when the ulnar radial head reduces. And in that position, I then put the plate. So it becomes easier for
So
handling.
you do plating with assistance of an external fixator.
Yeah. In a
And what
couple
is
of
the
cases,
percentage? What is the percentage where you had to open the radiocapitellar joint, and with your distraction you were not happy? So what is the percentage? You know.
I in a couple of cases I got it to reduce by itself, so I did not have to open it. But in a couple of few other cases, I have had to open them. And in one case, which we had shared earlier, sometimes in iFix also, there was a posterior intraosseous nerve palsy and the nerve was stuck in between. So I had to extricate the nerve. So that had to be opened.
Right.
But I have done a couple of where I have just maintained the distraction with the X-fix itself. And then once the osteotomy united, remove the external fixator by itself. So the advantage is it doesn't leave any implant inside and you can just remove the X-fix.
Was there any incidence of late redislocation in your series?
No.
No, not you remember. Yes, Dhiren bhai, what is your preference? An acute or gradual lengthening?
My preference is acute lengthening and to fix it with plate. The only reason or the disadvantage of acute lengthening and plate fixation is that you need a second surgery for removal of implant. That's the only disadvantage. Otherwise, I am very less pro for external
X-fix.
fixator, X-fix. That's the reason.
Right, right. So now we discussed already that how to decide the amount of flexion and distraction intraoperatively. Atul already talked about it, and this is the paper which Anirban was discussing, modified Hirayama technique, which is published in JBJS 2009, and they are doing a lot of templating on the pre-operative X-ray. But I'm sure that as all the faculties mentioned, this is more of intraoperative decisions rather than the pre-operative X-ray templating. Am I right, Atul? Do you want to add some point here?
No, that's right, because it's a very dynamic situation. So you have to measure intraoperatively. Pre-op assessment only will tell you where to make the osteotomy, but not the actual distraction.
Right. And this is a nice paper supplement from Donald Bay, which Anirban was mentioning, published in JPO 2016. And I would urge our delegates to read this paper. And they are doing an open reduction first, and then doing an reducing the joint, putting a temporary wire and ulnar osteotomy. They take the help of temporary K wire, and then in whatever position ulna comes, they fix the ulna and then remove the wire. So this is a nice paper to read. The question which we already discussed is, should we use transcapitular wire for stability? So Kapil, what is your experience? Have you required, by doing all the interventions, your radial head is not stable, and have you ended up using transcapitular wire ever, or it's big no for you?
No, Molin, never. I've never left the transcapitular wire in for stability. In fact, I've never even used it for templating my reduction.
Yeah.
But if at the end of surgery, if I do find that the radial head is not stable in alignment with the capitulum, I would not hesitate to add annular ligament reconstruction.
Fine. Rudra, what is your experience? Any incidents of transcapitular wire usage?
Yeah, and I mean, especially in the beginning, we used to use this transcapitular wire, especially in kids who are presenting very late. So we used to do the osteotomy, but somehow as you were discussing that there should be some amount of a space after reduction that we were not able to achieve it. And the moment we used to reduce the radial head, suddenly it used to pop out repeatedly. So just to make it stabilize, we started using this transcapitular wire, but it gave a very bad problems. In the moment we remove the wire, either it partially subluxates or it results in very bad stiffness. Even though logically it used to look nice, but there is no rotational movement. So I stopped using it. But as Anirban was telling, maybe there is a role for it only on the table.
Yes.
To put a temporary, probably a small wire, not to use a bigger diameter wire. And then, you can assess the osteotomy, the amount of distraction and everything. and probably it has got only a role there, but not to retain the wire for a long time. That's my
Right. Yes, Dr. Mida, what do you think about it? Do you have any experience with this? Because there are some papers
Actually,
who have used
being
this transcapitalar wire without any problem, but we all have faced complications. Sometimes the literature, we have to take with a pinch of salt, and when you practice, you don't want to burn your fingers every time. That's why these webinars are on. Yes, Dr. Mida, yeah.
Being a general orthopedic surgeon, in my experience with this late Montegia is not that big, but I always use a transcapital wire, though I take them out after 3 weeks and hope that it will stay. But yes, my results are not to boast, something to boast about, but yes.
So we in
They do
DDH we
cause.
say when you have to put a trans articular wire, there is something wrong with your reduction, or your releasing is not adequate. So similar point, we must, as a general orthopedic, if you want to take this thing, you please take help of some colleagues and do some cases. And it is very important to release the soft tissue or to treat the annular ligament well. Otherwise, it will come back, and that's a really challenging problem.
Yeah.
So these are the papers which shows capitular wire issues, that there is increased stiffness, and it is difficult of retrieval once the wire gets broken intraarticularly. So as Rudra very honestly mentioned, that transcapital wire had given him a very hard time. Now, the key question is, what is the role of annular ligament reconstruction? And our colleague Atul has published his paper in Indian Journal of Orthopedics. Is annular ligament reconstruction always required? That was published in IJO 2009. And so this is the case by Atul. And Atul, you have to take us through this case. So this is a 6 years old boy with 16 months post-index injury. And this is anterior dislocation with a quite proximal migration. Atul, you would like to comment, and I'll take you through the case. Yeah.
So this child, we did the classical words approach. I like to go between the bone, very close to the inconus and the bone itself, because you want to remove that fibrous ligament, which is going to block your reduction of the radial head. So I like to clear the entire space, all the fibrous tissue, and then we go ahead and do our osteotomy. And once we, do you have the slide, Mohan, the next slide?
I think I have this slide of how you construct it. So I don't have slides of osteotomy because we.
Okay, so what we do is we mark the site of the osteotomy in the proximal third, and we keep enough space in the proximal area in case you want to do a ligament reconstruction. You don't want to end up with a plate over your ligament. So you have to keep at least good 2 centimeters of distance from the tip of the olecranon rod. And you do the osteotomy, and after distraction to almost 10 millimeters, if you cannot reduce it, then I would take the lateral slip of the triceps, about 8 millimeters of the strip. And then I pass a whip stitch on the triceps, at the end of the triceps, and pass this ligament from the lateral to the middle side, and then reduce the radial head. You have to make sure that you don't dissect the part from the bone. If you sometimes to get length, you can be overzealous, and you can actually shave the entire ligament from the bone, and then you are stuck. Then you need anchors, or you need some kind of suture drilled holes to fix the ligament. If you can keep the ligament attached to the bone, the proximal ulna, it's then very easy to wrap it around your radial neck, and then tie it over to the remnant. The question is how tight you tie it. I've seen cases where in post-op you can get this osteolysis extremely tight. Because in the beginning, you want to be extremely enthusiastic about it. Secondly, you get this overgrowth of the radial head. Of course, they are X-ray findings. The child otherwise has got good range of movement. But these are problems with over-tightening, and you can always get an enlarged radial head. It's not because of like a coxal magnet you get in the femur. So, but that doesn't give you a bad result. The movement of the child is pretty good. The elbow is quite stable. So this is what you can expect after ligament reconstruction.
So I was just searching other papers, and in your series, Atul, did it make any great difference whether you did annular ligament reconstruction or not?
So to be honest, we had compared two groups of children, and the ones who were less than 10 months, it doesn't make any difference. The ones who were presented after 10 months of age of missed dislocation, those are the ones we had to do a ligament reconstruction. So this is not a randomized study.
Yeah.
But the lower the lesser the duration of dislocation, you really don't need a ligament reconstruction.
So there's one more paper which suggests that the palmar is longer is a better graft than the triceps fascia. And there are one more paper suggests what are the complications of annular ligament reconstruction. There are those patients had a higher degree of rotational restriction and recurrent subluxation. So higher degree of rotation restriction might be due to initially more graver injury or more bad Monteggia dislocation. But some of those patients, they had recurrent subluxation. The reason behind it is more the duration the radial head remains out, there will be changes of hypertrophy of radial head or hypertrophy of radial neck, which will not match to the radial groove on the ulnar side. And those are the problems. So this, I think this where we finish the Monteggia session. And Navin bhai, I'll be happy to take questions from delegates.
Okay, let me ask the questions. Yeah. Dr. Ravi Sauta from Delhi, he has asked the question.
Yes.
Anybody is doing the radial osteotomy if the radial head is reduced and but unstable? You are doing that ulnar osteotomy, but what about the radial osteotomy? It has been described or any experience of the faculty?
So I have done one case that was an 8 years old Monteggia dislocation, 8 years old index injury. And we tried open reduction and we did ulnar osteotomy distraction, but still the radial head was lying above. The first thing why I required to operate upon this child when I knew that after 3 years results are not good, that patient had a lot of pain and impingement and had cubitus valgus. So because of pain, I had to reduce this. So after doing ulnar osteotomy, which was not coming, I did a radial shortening osteotomy from the center of the radius and then fix it with a intramedullary nail, and that gave a good reduction and reasonably good outcome. The patient's pain disappeared, but he had some degrees of restricted rotation. So I had one incident, but there's no paper mentioning role of radial shortening osteotomy, or I am not aware. Is there any paper, Kapil or Anirban, in literature? No, but I have one case example. And another question.
Okay, let me check the other questions because there are so many, 2 or 3 people have shared their x-rays in case, but let me complete the question, then I will share the screen.
Yes.
For old isolated radial head dislocation, what is the treatment? I think it has been answered already previously.
Yeah. So
what is the minimum age at which you can do distal radius plating for distal and radius fractures also with this? I think this is not related to that part. Yeah. Distal radial plating. Any requirement for ulnar lengthening or shortening to accommodate the radial head?
That we discussed.
That we discussed already. We do this ulnar distraction. Yeah.
Anybody has a video of that surgery? That is always this demand comes.
So
more and more videos.
we have a nice video on YouTube. I will send the link, and that mentions everything.
Okay,
yeah.
so
we will send and
we'll send the link. Okay, okay. Back after ulnostomy, we have encountered that any tip to manage it.
Sorry.
Back after osteotomy. He has written a very half question. Any incidence of posterior introsseous nerve palsy in annular ligament reconstruction?
Yes, Atul, your experience?
I've never had posterior nerve palsy in Boyd's approach.
Yeah. The one question will be what plate you use for this?
Yeah.
Anirban or Atul, what plate or Mandar? Do you use a recon plate or semitubular plate or stack plate? So what is your choice of using implant? Mandar.
I usually use a recon plate if it's a very young child, but I will consider it using a DCP also. So typically, if it's a very young child, it's a recon plate which I use or a DCP.
So yeah, DCP's problem is a bit high profile,
it becomes too prominent. But recon plate is something which is very typically used by me.
Best plate which fits the contour of dorsum of ulna is a semitubular
One-third
plate.
tubular, yeah.
But its strength is not good. So
Correct.
Dr. Peter Waters tend to use a stacked semitubular plate, and that has been my practice also. So that fits well. But recon plates can be used, and DCPs in some
Even the
bigger children.
Synthes 2.7 plate. It's a very good
Yeah,
Okay.
2.7 plate.
Okay.
Okay.
How to
2.7 plate.
Yes, Navin bhai.
How to check the radial head stability after ulnar osteotomy and fixation, and go for that belt away procedure if required? That is the reconstruction of the annual ligament. How
the
you check on table?
So key thing is one is in extension and other is in supination. So supination and extension are the maneuvers where radial head will subluxate. So just don't check it in flexion and pronation, because in that the radial head will remain reduced. But in extension and supination, you should check that radial head should remain in. These are the two maneuvers which will guide you.
Okay. How to decide how much flexion given at the osteotomy site?
We have discussed that, and it's based on the intraoperative picture.
Probably
Yeah.
he has joined late, or he has not heard it.
Yeah,
Okay.
that Atul and Anirban has already mentioned.
Okay, I think all the questions are gone, but there are some X-rays said by the members. You complete it if the time remains, or you are completed yours.
I think we are done with this. Our side, so we can see the X-rays.
Okay. Let me check what the X-rays they have given to us. Dr. Praveen has then said about that what he had done. He has said that excision of the heterogenic ossification of the radius with open reduction and K-wire fixation kept for 3 weeks. After removal of K-wire, mobilized with X fixed with the hinge joint, no complications and no dislocation. Radius was medially, and he could get a good result. That was
great.
his, he had,
I think it's commendable. He got a good result from that.
And this question is from Dr. Jignesh from the Baroda.
Yes.
What should be the position of arm while Boyd's procedure? How exactly is the annual ligament tied? Where is it taken to, and how? Details of annual ligament thing, and the position of the arm while Boyd's approach. Position of the arm during the
Atul, you
Boyd's
want to
approach.
answer that question?
So typically the patient is in supine position, and we flex the elbow to 90 degrees. So an assistant across the table is holding the arm, so that we can easily, this helps in the imaging also. So we can get a good imaging instead of keeping in the lateral position. And the annular ligament is tied to the proximal ulna. We have to leave the attachment to the triceps attachment to the ulna intact. So when you wound it around the radial neck, you should fix it to the residual part of the triceps, attached to the proximal ulna. So it cannot be a free ligament. It should not be a free ligament. Otherwise, you will need bone anchors, and then you'll have to make drill holes. So typically, you will have to leave the attachment intact to the proximal ulna and tighten it back on that or the periosteum around the plate.
Okay. Somebody has said the case X-ray. I think. Let me check. X-rays are little poor, but we can, if can.
Meanwhile, I can share this 8-year-old. Should I share the screen, Navin bhai?
Yeah, you can. You can go ahead, no issue. We can change the screen anytime.
So I think this was the case. Can you see the Atul?
Yeah, we can see it.
Yeah, so this was a 14-year-old boy with progressive elbow valgus, and he had anterior bump and pain, and you can see that radial head was there. And this is 8 years old injury. So this is quite proximally migrated, cubitus valgus, and the bottom one is the normal side, and here is the affected side. So this is the boy where we had a lot of struggle. You can see the ulnar deformation also, and I used to measure this angle, this radial neck shaft angle and carrying angle difference. When it is more than 20 and more than 5 degrees or 10 degrees, these are challenging problems. So I'll show you what I did. So this is what I did. I did radial shortening here along with the distraction osteotomy, and this was so unstable. I had to put a temporary K wire. This is the only case where I had to use this temporary K wire. But in longer term, we removed the wire at 3 weeks, and he had fairly good reduction and good range of motion, and his pain went off. You can see the radial head is quite irregular here, and he had some early osteoarthritic changes. But this was the 3 years follow-up of that boy with improved range of motion and reduced cubitus valgus. But he had restricted terminal pronation and supination. So this was the case I was discussing. Yeah.
Similarly, a girl I had done for congenital radial head dislocation. She also had a similar restriction of movement. So these are not easy cases. You cannot guarantee full range of movement.
And this is what I was mentioned in Boston. They are doing now 3D printing of models to forecast whether this will be a futile exercise or something fruitful. Yes, Navin bhai, do we have any question?
Okay, yeah. This one has been said here. Let me check what he has written. We can go through. The young surgeon has said this. Sir, for acute Montilla case discussion, I have live case managed just last week in my OPD setting in lockdown. 3 years old girl, injury 1 day back, and he has said the pre-op injury X-ray. First attempt at reduction shows radial head posterior with ulnar plastic deformation anteriorly, and the second attempt with reduction in OPD under conscious sedation could not take to the OR because of the lockdown. Let us see his X-rays, what he wants to say.
Yeah, so there is a plastic deformation, and can you go to the next X-ray?
Yeah.
This good thing is he has taken. Now I'm not sure whether it is Montilla because there is a fracture at the proximal third of radius and the radiocapitellar line. Yeah, and radiocapitellar line is well maintained.
Yeah.
This is the oblique X-ray which gives an impression of.
Yeah. This is the reduction he had done.
Yeah. So there is no Montilla. This is just an double fracture. That's it. Green stick fracture of radius ulna.
Okay. This. Okay. It has been said, so we have shown it.
Yeah. So
they felt that it is a.
You are lucky. Don't worry.
Is there a component of the loss of the concavity of the radial head fossa articulating with the capitulum in neglected lesions, which thereby does not allow it to articulate back after ulnar osteotomy? We have encountered that. Any tip to manage that?
Yes, Mandar, you explained this point, and I think we all know this. More time it elapsed, and these are the changes. There is no tip or no trick. These will end up with restricted, compromised results.
So they have said it. That's all. Okay. Now I think it is over. Almost all questions we have taken.
So yeah, we thank all the faculty who has spent their valuable time and kept this webinar vibrant and interactive, and also the delegates who brought important questions.
And now, when the Dr. Dayanidhi has said when to reconstruct annular ligament not clearly discussed. He felt that he needs still clear-cut guideline when to reconstruct the annular ligament. He has written at 6:45 p.m.
So Atul.
So if you cannot get the head into position after doing an osteotomy, after doing your distraction flexion osteotomy, if your radial head is still unstable, then you should go ahead and do a ligament reconstruction. And ligament reconstruction will not help an unstable joint. That means you must clear the joint of the fibrous tissue. You must make sure that the fossa is clear. If you don't clear it and you go ahead with the ligament reconstruction, it will fail. So these points are very important. Clear the fossa, do the osteotomy. If it's not stable, after distraction flexion, then go and do a ligament reconstruction.
Okay, the same place Dr. Divyesh Joshi from the Surat is asking, any chance of non-union of the ulna at the osteotomy site? What is the incidence and what are the issues of non-union of ulnar osteotomy?
If it's more than 10 millimeters grafted, I have had patients with delayed union, not non-union.
Yeah.
Okay.
Yeah.
Okay. Quite
true. We have not seen many ulnar non-unions.
Yeah.
I've had delayed unions with some of the distracted ones.
Yeah.
I never used to graft them. In a couple of them, I just put synthetic bone grafts. So they all took a little time to heal, but it's described.
So the last comment has come from Dr. Dinesh Sharma from the Haryana. Congratulations to all the faculty and very nice presentation and discussion.
Thank you very much.
Right. So this is the
Great.
last thing came at 6:49 p.m. Right. So can I stop this streaming and then we can have a 2-minute chat? Right.
Yes. Thank
Sure.
you. Thank you,
Okay.
Navin.